now let us start with the cardiology quick revision. So what are all the topics which I'll be doing the quick revision in this cardiology session? That is congestive heart failure, cardiomyopathies, heart sounds, JVP, cardiac murmur, then arterial pulse, and all the valvular heart diseases. Mitral stenosis, mitral regurgitation, mitral valve prolapse, aortic stenosis and aortic regurgitation. Then infective endocarditis, rheumatic fever, and then coronary artery disease, systemic hypertension, pericarditis, constrictive pericarditis, and then we'll be also discussing the image based questions and as well as the previous year questions. Okay, so that will be the cardiology quick revision. Now let us start the discussion with the congestive heart failure. So if you see this congestive heart failure, you need to know one important clinical scenario. So the clinical scenario is that a 56-year-old man with a history of coronary artery disease and documented ejection fraction of 40% by echocardiography presents for further management. At this visit, the patient denies having shortness of breath, dyspnea on exertion, orthopnea, or lower extremity edema. He has never been admitted for congestive heart failure. So, according to the ACC, that is American College of Cardiology, guidelines for evaluation and management of heart failure, in what stage of heart failure does this patient belong to? That is stage A, B, C, D. Yes. So, which particular stage of the heart failure is this patient belongs to? Now, if you take the stages of heart failure, we have totally 4 important stages. That is stage A, B, C, D. Now, in case of the stage A, what is that you will notice is that the individual is at risk of heart failure, but there is no structural disease. What are the risk factors? That includes diabetes and as well as the hypertension. Whereas in stage B, these patients, they are having at risk of heart failure and they also have the structural disease and there is no heart failure symptoms. Whereas in stage C, these patients, they have the heart failure symptoms, that is in the form of dyspnea and all. Whereas stage D, it is like advanced stages of heart failure. These are the stages of heart failure. Now, if you go back to our patient is having the structural heart disease, that is coronary artery disease, and ejection fraction is less than 40%. But the individual is denying any symptoms. The individual is asymptomatic. So what is it suggestive of? This will be suggestive of the stage B of the heart failure. This will be suggestive of stage B of heart failure. Now, if you take the etiology of the heart failure, what do you think is the most common cause of the heart failure? See, left heart failure, we classify that based on ejection fraction. But whereas right heart failure, if you take what is the most common cause of right heart failure, that will be the left heart failure. And next question is, what is the most common cause of acute cor pulmonale? What is cor pulmonale? Initially, there will be right ventricular dilatation. Followed by that, there will be right heart failure. That is called cor pulmonale. Most common cause of acute cor pulmonale will be massive pulmonary embolism. Most common cause of chronic cor pulmonale, that will be the COPD, that is chronic obstructive pulmonary disease. Then if you take the left heart failure, we classify that based on the ejection fraction. Normal ejection fraction is 55 to 70%, right? And we classify this into the heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. Right? If you take heart failure with preserved ejection fraction, where the ejection fraction of the patient will be more than 50%. Whereas heart failure with reduced ejection fraction, where the ejection fraction of the patient will be less than 40%. Heart failure with preserved ejection fraction, like the etiologies include the cardiomyopathies, that is hypertrophic cardiomyopathy and as well as the restrictive cardiomyopathy. And even endomyocardial fibrosis, even that will also cause a heart failure with preserved ejection fraction. Reduced ejection fraction, that includes dilated cardiomyopathy, coronary artery disease, valvular heart diseases like MR and as well as AR, then aortic stenosis. So these are conditions which will cause the heart failure with ejection fraction. Now this is the classification of the heart failure. So if you take the manifestations of the left heart failure, what is the earliest manifestation? That will be development of paroxysmal nocturnal dyspnea. In the sense, the individual will develop dyspnea in the middle of the night. After 2 to 3 hours of sleep, immediately gets up because of sudden onset dyspnea. That will be paroxysmal nocturnal dyspnea. And as the severity progresses, they will have orthopnea, then dyspnea on exertion and dyspnea at rest. These are the features of the left heart failure. And regarding this particular dyspnea, the severity assessment is being done by the NYHA classification. So if you take this NYHA, what does this stands for? That is New York Heart Association. What are the components which have been described in NYHA? That includes fatigue, palpitations, and as well as dyspnea. And remember, angina is not the component of the NYHA. So if you take the NYHA class 1, in this individual, there is no limitation of the physical activity. In the sense, ordinary physical activity does not cause any symptoms. Only the individual, if he does any exertional activity, then there will be dyspnea. That is class 1. Then what is class 2? Class 2 is that where there is slight limitation of the physical activity. These patients, they are comfortable at rest, right? They are comfortable at rest. And ordinary physical activity, they will cause the symptoms. Then you take class 3, where there is marked limitation of the activity. That means whenever the individual does less than ordinary activity, even that also cause the symptoms. Class 4 is that the individual is unable to carry out any physical activity without discomfort. That means dyspnea at rest. That will be your class 4. So this is about your NYHA classification. Then what is the earliest manifestation of right heart failure? Remember, the hepatojugular reflex will be positive. That is the earliest manifestation. Then followed by that, the JVP will be raised, and other manifestation of right heart failure will be, there will be tender hepatomegaly and pedal edema. Subsequently, they can also develop portal hypertension, ascites, and then splenomegaly. These are the features of the right heart failure. Now, on examination, what is a characteristic breathing pattern in patients with heart failure? They have the characteristic breathing pattern that is called Cheyne-Stokes respiration or Cheyne-Stokes breathing, where the individual will have increase in respiratory rate for a certain period of time, and then there will be apnea. Followed by that, again there will be increase in the respiratory rate. This is what is called Cheyne-Stokes respiration, characteristically seen in congestive heart failure. Then in patients with congestive heart failure, what is the name of the criteria for your congestive heart failure? That is Framingham's criteria, in which you have major and as well as the minor criteria for diagnosing heart failure. And what is the diagnostic methodologies by which you can diagnose that the patient is having heart failure is that we have cardiac biomarkers, then imaging in the form of your chest x-ray, ECG, 2D echo. These are all the various diagnostic procedures. Now, if you take the chest x-ray, what all will be the chest x-ray findings? So, the chest x-ray findings, if you observe very clearly, this will be the earliest manifestation. What will be that earliest? You will have upper lobe vein distension. That will be the earliest manifestation of the left heart failure. Then followed by that, the fluid from the capillaries, they enter into the interstitium of the lung, and that will result in interstitial edema. And that interstitial edema will be given in the form that will give you the picture of the curly B lines, right? This is nothing but your interstitial edema, curly B lines. And followed by that, the fluid from interstitium will enter into the alveoli. That will result in the alveolar edema, right, where you have alveolar infiltrates. And subsequently, the fluid from the alveoli will enter into the pleural space, resulting in pleural effusion. So this will be the chest x-ray picture in patients with the congestive heart failure. And next important is the cardiac biomarkers. Now, we have these 4 cardiac biomarkers which will be elevated in patients with the congestive heart failure, but the one which is most sensitive, right, the one which is most sensitive, diagnostic, therapeutic, prognostic is your NT-proBNP, right? And this NT-proBNP, it is released from the ventricles of the heart. And atrial natriuretic peptide is that which is released from the atria. Then adrenomedulin is another cardiac biomarker, and then we have endothelin 1. Now, what is this endothelin 1? Endothelin 1, it tells you about the vascular resistance, and that is being elevated in patients with the congestive heart failure. Okay, but the most sensitive cardiac biomarker is the NT-proBNP. Then you take the management in patients with the congestive heart failure. So if the question is asked, what is the drug of choice for acute left ventricular failure? It is a loop diuretic, that is furosemide. Because in acute left ventricular failure, the individual will develop pulmonary edema. In order to flush out the pulmonary edema, what we require is the furosemide. Okay. Then what are the other various treatment options for acute heart failure? See, if the question is asked next line management, then it should be the oxygen and as well as the ventilatory support depending upon the saturation. Saturation you need to maintain more than 94%, right? And the diuretic will be the first important drug of choice. That will be the furosemide. Then what is the role of morphine and as well as vasodilators? The morphine and vasodilators, they reduce the preload. That means they reduce the venous return to the heart and thereby reducing the cardiac workload. And vasodilator that you give is the nitroglycerin. But please remember, whenever you are giving nitroglycerin, you have to ensure that the blood pressure of the individual is more than 90 millimeters of mercury. right? And another important vasodilators that we have is levosimendan. Then coming to your inotropic agents. When will you give inotropic agents is when the systolic blood pressure of the patient is less than 90. That is the point when we need to give inotropic agents, that is noradrenaline, dopamine, or dobutamine should be given. Dobutamine is given in case of the cardiogenic shock. Okay, right. So these are the treatment options for acute left ventricular failure or acute heart failure. Then if you take the drugs for chronic heart failure, see the drugs which will improve the mortality, right? In the sense, the drugs improve the mortality in the sense it is not that which will increase the mortality. These are the drugs which will decrease the mortality and thereby the mortality can be prevented. These drugs include beta blockers, ACE inhibitors or angiotensin receptor blockers, and then aldosterone antagonist. And these beta blockers, like what are the beta blockers that we need to give is bisoprolol, metoprolol, and then carvedilol. These are the beta blockers that we give in the treatment of congestive heart failure. And metoprolol, we have two formulations, metoprolol succinate and metoprolol tartrate. What we give is metoprolol succinate that we give in the treatment of the heart failure. Okay. And whenever you are starting this beta blockers, you have to start the beta blockers with low dose, and then gradually you need to increase the dose of, right? Gradually you need to increase the dose of your beta blockers. Yeah, Ravi Kiran, dobutamine will not increase the blood pressure. Dobutamine you need to be given, you should be giving carefully whenever there is low blood pressure. Okay, right. And these beta blockers, they should be started with low dose, and then you need to step up the dose of this dobutamine. Sorry, dose of your beta blockers, right? And the next important point is the beta blockers are contraindicated in case of class 4 NYHA. In class 4 NYHA, they should not be given at all. Okay, right. Now, in heart failure with reduced ejection fraction, what is the preferred drug? The preferred drug will be valsartan plus sacubitril. So valsartan is what? It's an angiotensin receptor blocker, and sacubitril it is an neprilysin inhibitor. So this we call it as ARNI. So this particular combination, that is ARNI, what has been found is it has been found to improve the ejection fraction of the patient. Okay. Then the next important is what is the drug of choice that is given in heart failure which is associated with the atrial fibrillation. So in that particular patients, we need to give digoxin, because digoxin will not only improve the cardiac contractility, will also increase the refractory period at the level of AV node, thereby it will reduce the atrial fibrillation. And next important question is what is the good choice of drug for diabetes, for diabetics at risk of heart failure, that is SGLT2 inhibitors, that is dapagliflozin should be given. Dapagliflozin, it is actually a new molecule which is given in the treatment of diabetes mellitus, and these diabetics who are at risk of your heart failure, in them you need to give this dapagliflozin that can prevent the development of the heart failure. Now, one of the important image based question which was asked as a PYQ, the image shows the presence of implantable cardioverter defibrillator, cardiac resynchronization therapy, dual pacing, transvenous pacemaker. Now, if you observe this carefully, this is the cardiac pacemaker. Sorry, cardiac resynchronization therapy. Why is that you are considering it as a cardiac resynchronization therapy? You have one lead in the right atrium, you have a second lead in the right ventricle, and third lead which is present in the lateral wall of the left ventricle. So now in case of implantable cardioverter defibrillator or in case of dual chamber pacemaker, you will have only two leads, and in transvenous pacemaker, so you will have only one lead, that is in the right ventricle. And in case of cardiac resynchronization therapy, you will have three leads. Okay, right. Then followed by that about the interventions. Interventions, what are all the interventions apart from your cardiac resynchronization therapy? The other interventions which can be done is the ICD. Now, which group of individuals of heart failure they will be requiring the implantable cardioverter defibrillator? So this is a very important flowchart or very important table. So those patients where the LV ejection fraction is less than 35% and it has become more than 1 year or more than 40 days after post myocardial infarction, if the patient is still having NYHA class 2 class 3 symptoms, he is the candidate for implantable cardioverter defibrillator because they are at increased risk of sudden cardiac death. Then what about CRT? What is the indication for that? The individual is having ejection fraction less than 35% and the individual is having class 2 to 4 symptoms and QRS complex is more than or equal to 150 milliseconds with left bundle branch block. they are the candidates who will be requiring this CRT, cardiac resynchronization therapy. Now, in spite of your ICD or in spite of your CRT, if the patient is still refractory, that means the individual is in a state NYHA class 3 or class 4, in spite of placing your CRT, then they are the candidates who require the cardiac transplantation, who require the LVAD, that is left ventricular assist device. So, so this is about like who requires the intervention is very important point. So this table is very important. Just please do a quick revision just before going to your exam. Okay, right. Then, so that was about your heart failure. Now let us discuss about the cardiomyopathies. So cardiomyopathies is what exactly? Cardiomyopathy. So where there is disorder within the cardiac muscle, right? Where there is disorder within the cardiac muscle. That is what is your cardiomyopathy. So we have three forms of cardiomyopathy, that is dilated cardiomyopathy, then we have hypertrophic cardiomyopathy, and then we have restrictive cardiomyopathy. So these are the three forms of the cardiomyopathies, out of which the most common form of cardiomyopathy will be your dilated cardiomyopathy. Now let me discuss like some of the important previous year questions and as well as in detail about these cardiomyopathies. So if you take this clinical scenario, that is a 44-year female, known case of breast cancer, is on chemotherapy since 2 years. She is HER2 receptor positive breast cancer and she is on some chemotherapeutic drug, right? She is on some chemotherapeutic drug and that chemotherapeutic drug is being taken subcutaneously. She presented to the emergency department with history of dyspnea. What is the drug is this particular patient taking? Adriamycin, trastuzumab, daunorubicin, then cyclophosphamide. So the correct answer here is the trastuzumab. So the trastuzumab is the drug. See, all these chemotherapeutic drugs, they can cause the dilated cardiomyopathy. But the trastuzumab is the one which is given in HER2 receptor positive breast cancer, and that is the one which is given subcutaneously, and that can cause the dilated cardiomyopathy, and that is the reason why the individual is having dyspnea. So the answer here is the trastuzumab. Now if you take the toxins causing cardiomyopathy, the most common toxin will be the alcohol. Then what are the other toxins? That is chemotherapeutic drugs, that is adriamycin, trastuzumab, daunorubicin, and as well as the cyclophosphamide. Then if the question is asked what are the inflammatory causes for dilated cardiomyopathy, that includes mainly the autoimmune conditions like your Graves and all. Then post-infective conditions. So these are the inflammatory pathologies that can cause the dilated cardiomyopathy. And what are the autoimmune conditions? That includes systemic lupus erythematosus, Graves, then systemic sclerosis, and then dermatomyositis. So these are the autoimmune conditions which can cause the dilated cardiomyopathy. Then what are the nutritional deficiencies that can cause dilated cardiomyopathy? That is selenium deficiency and as well as the thiamine deficiency, right? And this selenium deficiency, the new terminology that we give is the Keshan disease, right? Then what are the endocrine causes for dilated cardiomyopathy? That is diabetes mellitus, hypo, and as well as the hyperthyroidism. Next, followed by that, what are the hematological causes for dilated cardiomyopathy? That is mainly the sickle cell anemia. Please remember, it's a very important point. And infiltrative causes for dilated cardiomyopathy will be hemochromatosis. And this hemochromatosis will not only cause dilated cardiomyopathy, it can also cause the restrictive cardiomyopathy as well, right? Then, what are the neuromuscular causes for dilated cardiomyopathy? That is muscular dystrophy. And what type of muscular dystrophy? That is Duchenne's muscular dystrophy, Friedreich's ataxia, and then myotonic dystrophy. So these are the neuromuscular causes for dilated cardiomyopathy, right? Now, what will be the clinical features in dilated cardiomyopathy? The clinical features will be similar to that of heart failure, because all these cardiomyopathies, they will make the individual to land up in heart failure only. So they will have your right heart failure symptoms and left heart failure symptoms, what we have discussed in the heart failure. Then how will you diagnose the cardiomyopathies? Like if you take dilated cardiomyopathy, when you do a chest x-ray, you will notice that there is cardiomegaly. What is the criteria? So if you take the cardiothoracic ratio, right? If you take the cardiothoracic ratio, it should be more than 0.5 in case of adults. And what should be the cardiothoracic ratio in neonates to call it as cardiomegaly? That should be more than 0.4. Okay, so that is a criteria to call it as the cardiomegaly. Then after having discussed about the chest x-ray, the other method by which you can diagnose dilated cardiomyopathy is your 2D echo. 2D echo, that will be showing the heart failure with reduced ejection fraction, right? Heart failure with reduced ejection fraction. So ejection fraction will be less than 40%. And not only that, you will notice that the chambers are completely dilated. Okay, and through these dilated chambers from the left ventricle, the blood will enter into left atrium. From right ventricle, the blood will enter into right atrium. And that we call it as the functional mitral regurgitation and functional tricuspid regurgitation, right? So, and in these individuals, the cardiac biomarkers, that is NT-proBNP and as well as the ANP, these are elevated. NT-proBNP and as well as the ANP, these are elevated. Okay. Then next is the treatment. Which of the following drug is not given in dilated cardiomyopathy? Beta blockers, calcium channel blockers, spironolactone, and ACE inhibitor. Remember, dilated cardiomyopathy, the ejection fraction is reduced. So, your calcium channel blockers should not be given in patients with the dilated cardiomyopathy. That's a very, very important point, right? And the remaining all drugs, like similar to that of your heart failure, furosemide we give. And once the individual is stabilized, we give beta blockers, ACE inhibitors, and then aldosterone antagonists. Okay, then now you take the another scenario which is causing dilated cardiomyopathy, that is 24-year male patient presented with history of ataxia of gait with Romberg sign positive and dysmetria. He also complains of dyspnea on exertion. Echo showed the ejection fraction of 30% with dilated chambers. What would be the likely etiology in this patient? Cerebellar ataxia, Friedreich's ataxia, subacute combined degeneration of spinal cord, then selenium deficiency. So the patient is having ataxia, Romberg sign being positive, the patient having dysmetria, along with the dilated cardiomyopathy is there. So where do you come across this? You come across this in patients with the Friedreich's ataxia, where the individual develops Friedreich's ataxia due to gene mutation, that is frataxin gene mutation. We'll be discussing in detail about Friedreich's ataxia in the neurology. Okay, so Friedreich's ataxia is one of the important neurological condition which can cause the dilated cardiomyopathy. Now you should know what is the indication of this device in dilated cardiomyopathy with left bundle branch block patient. So what exactly is this device now? If you see, you have three leads. One lead in right atrium, second lead is in the right ventricular apex, and the third lead is in the lateral wall of the left ventricle. So it is the QRS duration should be more than 150 milliseconds. Okay, so dilated cardiomyopathy, right, where the individual is refractory, to medical management, and the QRS complex, if it is more than 120, or if the patient is having left bundle branch block, the QRS complex should be more than 150 milliseconds. They are the candidates who will be requiring this CRT. What exactly is this CRT? That is cardiac resynchronization therapy. So that was about your dilated cardiomyopathy. And another important form of dilated cardiomyopathy is peripartum cardiomyopathy. So peripartum cardiomyopathy, it is that the development of features of dilated cardiomyopathy in a pregnant female in the last month of pregnancy or within 6 months of delivery. And in these patients with peripartum cardiomyopathy, please remember there is absence of demonstrable cause for heart failure. That means the pregnant female should not be having any pre-existing cardiac pathologies, right? Should not be having any pre-existing cardiac pathologies. Now, what are the risk factors for the development of peripartum cardiomyopathy? Risk factors include preeclampsia, that is hypertension, which will increase the afterload on the heart. Multiparous female, then elderly females. These are the group of individuals who are at risk of development of peripartum cardiomyopathy. Now, what are the drugs that we need to give in these patients? That is beta blockers, that is sotalol, right? Then this particular sotalol is acceptable to prevent the ventricular and as well as atrial arrhythmias secondary to your dilated cardiomyopathy. Then you need to give diuretics because the individual may develop the pulmonary edema. Hydralazine and nitrates should be given to reduce the afterload on the heart. Then why is that you need to give bromocriptine? Why is that you need to give bromocriptine is the pathogenesis in the development of peripartum cardiomyopathy is the fragments of prolactin which have been released excessively are responsible for peripartum cardiomyopathy. So we don't want prolactin to be released at all in this scenario. So you give bromocriptine, which is a dopamine agonist which will decrease the prolactin levels. Okay, right. And another important form of dilated cardiomyopathy is the Takotsubo cardiomyopathy, right? And this Takotsubo cardiomyopathy, we give it by the other many names: stress cardiomyopathy, apical ballooning syndrome, broken heart syndrome, and as well as the Takotsubo cardiomyopathy. So Takotsubo cardiomyopathy, why is it this name given? Because the apex of the heart which is being ballooned out is looking similar to that of an object used in Japan to catch the octopus. And what is that object used in Japan to catch the octopus? That is your Takotsubo. That is the reason why it is called Takotsubo cardiomyopathy. And pathogenesis is that when the individual is exposed to severe stress, there is development of Takotsubo cardiomyopathy. That is the reason why stress cardiomyopathy. And why is it called apical ballooning syndrome? It is mainly the apex of the heart which is getting ballooned out. That is why it is called apical ballooning syndrome. And this particular apex of the heart which is ballooned out, there is high chance that it can rupture. And that is the reason why it is broken heart syndrome. Now, in case of this Takotsubo cardiomyopathy, you have a criteria. And what is the name of the criteria for Takotsubo cardiomyopathy? That is modified Mayo's criteria. There are 4 criteria. 4 out of 4 should be there to call it as Takotsubo cardiomyopathy. What is that? There should be number 1, hypokinesia of the ventricle on 2D echo. Then coronary angiogram should be absolutely normal. There should not be any thrombus. ECG will be showing ST segment elevation and cardiac troponin will be elevated. Then absence of pheochromocytoma. Why? Because in pheochromocytoma also there is massive release of catecholamines similar to that of stress. So there should be absence of pheochromocytoma to call it as Takotsubo cardiomyopathy, right? So that is about your Takotsubo cardiomyopathy, modified Mayo's criteria which require all the 4. Now treatment is similar to that of any acute MI, that is we give aspirin, beta blockers and as well as the AC inhibitors. But only the point is if the patient with Takotsubo cardiomyopathy lands up in cardiogenic shock, then we don't give these beta blockers or ACE inhibitors. Once the patient lands up in cardiogenic shock, we immediately place the individual on IABP, that is intra-aortic balloon pump. This intra-aortic balloon pump will increase the diastolic pressures within the aorta and will increase the myocardial perfusion. And in that way, it will increase the myocardial contractility and thereby improves the blood pressure. So that is what is your IABP, intra-aortic balloon pump. And remember, intra-aortic balloon pump, it is contraindicated in patients with aortic regurgitation and as well as it is also contraindicated in patients with the aortic dissection. Okay, so that is about your cardiogenic shock. And there are certain drugs that should be avoided in case of the Takotsubo cardiomyopathy. What are those drugs? That is dopamine and as well as dobutamine. They should not be given. Why? And even norepinephrine. Why? Because Takotsubo cardiomyopathy itself is a condition where there is excessive catecholamine levels. And upon that, if you give your norepinephrine, dopamine or dobutamine, that can further precipitate your Takotsubo cardiomyopathy, right? And the important complication is these patients, they are at increased risk of sudden cardiac death. So that was about your dilated cardiomyopathy. And the next important form of cardiomyopathy is the hypertrophic cardiomyopathy. So it is the scenario where you will have heart failure with preserved ejection fraction. Later, right? Later, this can turn into a scenario of heart failure with reduced ejection fraction. But initially, it will be heart failure with preserved ejection fraction. Now, you see this question. All are true regarding the specimen which have been shown except asymmetrical septal hypertrophy, left ventricular outflow tract obstruction, diamond-shaped cavity of the left ventricle, diastolic dysfunction. So, please remember, you will not have diamond-shaped left ventricular cavity in hypertrophic cardiomyopathy. The cavity will be banana-shaped left ventricle. That is what you will have in patients with a hypertrophic cardiomyopathy, right? And what did I tell you? It is a heart failure with preserved ejection fraction. That means what? It is a scenario where you will have diastolic dysfunction, right? It is a scenario where you will have diastolic dysfunction. And when we are using the word hypertrophic cardiomyopathy, what should be the increase in the thickness of your LV? That should be more than 1.5 centimeters thick. That is a criteria to call it as the hypertrophic cardiomyopathy. So you see here. So this is the increase in the thickness of the septum, right? Increase in the thickness of the septum. So if you take in this entire left ventricle, only the septum is getting hypertrophy. And that is the reason why, and that too not the entire septum, it is only the base of the septum. So that is the reason why it is also called asymmetrical septal hypertrophy. And because of the septal hypertrophy, it is obstructing left ventricular outflow tract. That is the reason why it is also called hypertrophic obstructive cardiomyopathy. And this particular hypertrophy need not be only at the level of the septum. The hypertrophy can be even at the level of the apex. So that is the reason why this is also called as the apical hypertrophy. So remember, in case of hypertrophic obstructive cardiomyopathy, the LV lumen will be banana-shaped left ventricle. Whereas in case of the apical hypertrophy, what is that? You will have the shape of your LV in case of apical hypertrophy will be the ace of spades, right? It will be similar to that of ace of spades. So you can see that here. So this is your hypertrophy, right? So it is, so ace of spades in apical hypertrophy, banana shaped LV in case of your septal hypertrophy. Now, what is the etiologies? What are the etiologies that will be causing your hypertrophic cardiomyopathy? The etiologies that will be causing, it is mainly a genetic disorder, and the type of inheritance is autosomal dominant type of inheritance, and it is mainly due to gene mutation. And the most common gene that is being mutated is the beta myosin gene, which is present on the chromosome 14. And what are the other genes which are being defective? That is myosin binding protein C and as well as the troponin T. So these are the mutations which are responsible for the development of hypertrophic cardiomyopathy. And if you take the clinical presentation in these patients, most of these patients, they are asymptomatic and they directly present with sudden cardiac death. And if at all, if they are symptomatic, the most common symptom will be dyspnea. And why is that? That is because of diastolic dysfunction causing pulmonary edema, causing dyspnea. And what are the other symptoms that can be there? Right? What are the other symptoms that can be there in patients with the hypertrophic cardiomyopathy? The other symptoms that includes giddiness, because there is decreased cardiac output resulting in decreased cerebral perfusion, right? And these patients, they can also have palpitations because your hypertrophic septum or hypertrophic left ventricle will be arrhythmogenic, thereby there will be palpitations. So dyspnea, giddiness, palpitation, and they can also have syncopal attack. And those individuals with hypertrophic obstructive cardiomyopathy with syncopal attacks, they are at increased risk of sudden cardiac death. And another important clinical manifestation is angina, because it's a hypertrophic septum. The requirement of blood is more, myocardial oxygen demand is more, but supply will be less because of decreased cardiac output, and thereby the individual will also have angina. But if at all, if they are symptomatic, the most common symptom will be the dyspnea. Then, now, what is the important examination finding in patients with the hypertrophic cardiomyopathy? So if you take the pulse, they will have a characteristic pulse that we call it as the pulsus bispherians, right, where you have two peaks in systole, and you will have double carotid upstroke, right? You will have double carotid upstroke, okay? And the impulse, they will have double apical impulse, okay? And on auscultation, along with S1 and S2, you have S4. Why? Because your left ventricular pressure is very high, and if atria has to send the blood, there need to be a strong atrial contraction, and thereby you will have an additional sound, that is the S4. Then you need to know the murmur. The murmur is a harsh systolic diamond shaped murmur will be there. It is the ejection systolic murmur, which is nothing but the mid systolic murmur. And you have to remember that this particular murmur in dynamic auscultation, in this murmur is very, very important. The intensity of the murmur increases wherever the LV volume decreases. What are the conditions where the LV volume decreases? The conditions where the venous return decreases, right? So the conditions where the LV volume decreases, the murmur increases. Which conditions LV volume decreases? The conditions where there is decrease in your venous return. So what are the conditions where there can be decrease in venous return? Sudden standing, Valsalva maneuver, passive leg raising, drugs like diuretics, drugs like nitroglycerin, right, and digoxin, sympathomimetics. These are all the conditions the murmur increases, okay? Any condition which is decreasing venous return, or any condition which is increasing the obstruction. So whenever the LV volume decreases, the LV obstruction increases, and thereby the murmur increases. And the conditions where the murmur decreases is whenever the LV volume increases, right, and whenever the obstruction decreases, then the intensity of the murmur also decreases. So where do you come across this? Like, so when will the LV volume increase? LV volume will increase whenever the venous return increases. So what are the conditions where the venous return increases? That is, in supine position, the venous return increases, right? In supine position, venous return increases. I'm very sorry. Passive leg rising, even venous return increases, right? Passive leg rising, the venous return increases, okay? So in all these conditions, wherever the venous return increases, LV volume increases, and then obstruction decreases, the murmur decreases. And even your beta blockers, calcium channel blockers, they decrease the cardiac contractility. So whenever they decrease the cardiac contractility, the LV volume increases, obstruction decreases, and even murmur also decreases, okay? Right. Then how do you investigate these patients with your hypertrophic cardiomyopathy? That is your 2D echo. So 2D echo will show you that the ejection fraction will be preserved. And one of the very, very important finding is SAM. What is SAM? It is systolic anterior motion of the mitral valve leaflet. Right? What is SAM? systolic anterior motion of mitral valve leaflet. That is what you will see in patients with a hypertrophic cardiomyopathy. See, this you come across in a normal individual. In a normal individual, what is that you are seeing? The mitral valve will close whenever the left ventricle is contracting. But in case of hypertrophic cardiomyopathy, when the left ventricle is contracting, the mitral valve leaflet, it will move towards the hypertrophic septum, and that is what is called systolic anterior motion of the mitral valve leaflet. And why is that due to? That is due to decreased tethering force by the chordae tendineae due to hypertrophied left ventricle. Okay, so that is what is called SAM. Then next important is the ECG. What is that you will see in the ECG is you will have deep dagger shaped Q waves, right? Deep dagger shaped Q waves. Now where all you will get this deep dagger shaped Q waves? You get this in precordial leads, that is in V5 and as well as V6. Apart from that, in 2, 3 AVF, you will have deep dagger shaped Q waves. Then you will have the features of LV strain pattern. What is that? There will be asymmetrical T wave inversion. These are the features of LV strain pattern. This will be the ECG picture in patients with the hypertrophic cardiomyopathy. Then you should know what is the treatment in patients with the hypertrophic cardiomyopathy. So the 9-month-old child of diabetic mother presents with tachypnea and hepatomegaly. Echocardiography of the heart showed normal cardiac morphology with asymmetrical septal hypertrophy. Which of the following you will giving to treat the child? This is one of the PYQ. So now, what is this? It is a feature, it is a diagnosis of asymmetrical septal hypertrophy. So what is the drug of choice for asymmetrical septal hypertrophy? That is propranolol. Remember, digoxin, furosemide, nitroglycerin, sympathomimetics, they are contraindicated in patients with the hypertrophic cardiomyopathy. Now, propranolol should be given, and wherever the propranolol is contraindicated, we can give calcium channel blocker, that is verapamil. And first and foremost, very important advice that you need to give in this individual is avoidance of strenuous physical activity, right? Avoidance of strenuous physical activity, that is very, very important. Now, if with medical management, if the patient is not responding, then surgical treatments are there. What are the surgical treatments? That is alcohol septal ablation, right? ASA stands for alcohol septal ablation. Then surgical myomectomy can be done. These are the surgical treatments in case of hypertrophic cardiomyopathy. So we are done with the hypertrophic cardiomyopathy. Then, so in hypertrophic cardiomyopathy, what are the drugs contraindicated? Digoxin, sympathomimetics, then diuretics, then nitroglycerin. Then next is the restrictive cardiomyopathy. So restrictive cardiomyopathy, it is also the scenario where it is a heart failure with preserved ejection fraction, right? That means what? It is a scenario of diastolic dysfunction. Now, in case of restrictive cardiomyopathy, what happens exactly is some abnormal material come and get accumulated within the myocardium. Once the abnormal material gets accumulated within the myocardium will be very stiff and it cannot relax, right? Myocardium becomes very stiff and it cannot relax, resulting in diastolic dysfunction and heart failure with preserved ejection fraction. And if you see, the most common cause of restrictive cardiomyopathy, that will be amyloidosis. And that too within the amyloidosis, which form of amyloidosis? That is AL type of the amyloidosis. And apart from that, we have many storage disorders, that is the Fabry's disease. And in Fabry's disease, what exactly is this? This is a lysosomal storage disorder, and the enzymatic defect is the alpha galactosidase A deficiency that will result in Fabry's, right? Then next important is, which is the antibody in this condition that can cause the restrictive cardiomyopathy. So you can observe the image of this individual. The skin is like completely tight and the individual is unable to open the mouth completely, that is microstomia. So this is a feature suggestive of your scleroderma. And in which form of scleroderma you can have this restrictive cardiomyopathy? That is diffuse scleroderma. So in diffuse scleroderma, the antibody that you will have is the anti-topoisomerase antibody. So scleroderma is that diffuse scleroderma is one condition which will be causing the restrictive cardiomyopathy, right? Then followed by that, yes, what is the adverse effect of the drug used for the treatment of the following condition that will be causing restrictive cardiomyopathy? So what is that you are noticing here? That is bilateral hilar lymphadenopathy is there. Where do you come across this most commonly? That is in sarcoidosis. So remember, sarcoidosis is one condition which will be causing restrictive cardiomyopathy. And what is the drug that we give in sarcoidosis? That will be your corticosteroids. That will be the drug of choice. And what will be the adverse effect with your corticosteroids? That will be the peptic ulcers. right? Weight loss will not be there with corticosteroids, weight gain, that because it is Cushing's, and proximal muscle weakness will be there, and psychosis will be there, not dementia. Okay, right. Then now in these patients with restrictive cardiomyopathy, what will be the clinical manifestation? You will have the clinical features of the heart failure, that is your dyspnea and all. And apart from that, in these patients with restrictive cardiomyopathy, what will happen to your ventricles? Ventricles, they are unable to relax completely. So the atrial pressures, they increase. Once the atrial pressure is increased, what will happen to the size of the atria? The size of the atria increases. The size of the atria increases. And this increased atria will be arrhythmogenic, where there will be development of the atrial fibrillation, right? And because of atrial fibrillation, the patient can have palpitations. And not only that, in this distended atria where there is development of atrial fibrillation, there is stasis of the blood. And once there is stasis of the blood, there can be thrombus formation, right? There can be thrombus formation. And this particular thrombus, which has formed within the atria, it is like it can rupture, and where there can be emboli. So thromboembolic complications are seen in patients with the restrictive cardiomyopathy, right? Then on examination, what is that you will have in restrictive cardiomyopathy? The JVP will be elevated, and within the JVP you will have the abnormalities, that is deep X and Y wave, and Kussmaul sign will be positive. What is Kussmaul sign? Jugular venous distension on inspiration is called as the Kussmaul sign. Normally, what will happen to the jugular vein? There will be fall in your jugular venous pulsations during inspiration in a normal individual, but jugular venous distension, if it occurs during inspiration, that we call it as the Kussmaul sign, right? And what will be the other important examination findings? They can have hypotension, and the heart sounds, they can be muffled depending upon the etiology, right? Then and in these patients with restrictive cardiomyopathy secondary to amyloidosis, they will never have S4. They will never have S4. Why? Because amyloid material gets accumulated within the atria, so you will not have a forceful atrial contraction. So they will never have the S4. Okay. Then, how do you diagnose these restrictive cardiomyopathy? One is your 2D echo and the other one is ECG. So in ECG, what is that you will notice is, you will notice the presence of low voltage complexes, right? You will notice the presence of low voltage complexes. What is that? Less than 10 mm in the chest leads and less than 5 mm in the limb leads. That is what you will have in case of the restrictive cardiomyopathy. And echocardiogram, if you see, what is that you will have? The heart failure with preserved ejection fraction. And this echocardiogram, you will notice the speckled pattern in case of amyloidosis. In case of amyloidosis, you will notice the speckled pattern within the myocardium. That is characteristic in patients with the amyloidosis. And you will also notice that there is the atrial distension. And there can be functional MR and as well as the functional TR. Then how do you treat these patients with the restrictive cardiomyopathy? That is, you need to give diuretics because the individual will end up in heart failure and the pulmonary edema. So you need to give the excessive diuresis, and thereby the pulmonary edema can be reduced, right? Then now, what did we discuss? There is thromboembolic events that can happen because of the atrial distension causing atrial fibrillation. So in order to prevent the thromboembolic events, you need to give the anticoagulants. And one more important point regarding the treatment is the digoxin. Can we give digoxin in restrictive cardiomyopathy? Remember, digoxin should be avoided in restrictive cardiomyopathy because it can precipitate the arrhythmias. So, no digoxin in restrictive cardiomyopathy. So, that was about your cardiomyopathies. Dilated cardiomyopathy, peripartum cardiomyopathy, Takotsubo cardiomyopathy, hypertrophic cardiomyopathy, and restrictive cardiomyopathy. Now, once we are done with the cardiomyopathies, we will take up some basic topics: heart sounds, cardiac murmurs, arterial pulse, and JVP. So, these are the topics which we will be discussing now. Now, the very important PYQ was on the herbs point, right? So, you have the various areas of auscultation, that is aortic area, pulmonary area, herbs point, tricuspid area, and as well as the mitral area. So, where exactly is your herbs point? Please remember, it is present in the third left intercostal space, left parasternal line. Okay, this is one of the important PYQ. And these are all the remaining areas of auscultation. Aortic area is in the second right intercostal space parasternal line. Pulmonary area, it is in the second left intercostal space parasternal line. Herbs point, third left intercostal space parasternal line. Tricuspid area, fourth left intercostal space parasternal line. Mitral area, it corresponds to apex, right? Which is usually in the left fifth intercostal space in the midclavicular line. Next is the Gibson's area. Where exactly is your Gibson's area? That is in the first left intercostal space in the parasternal line, and in the Gibson's area you will listen Gibson's murmur, which is nothing but your PDMR. Okay, then you need to know the all the heart sounds. So in which phase of the cardiac cycle you listen these particular heart sounds? So S1 you listen that in isovolumetric contraction phase. S2 you listen that in protodiastole, right? Whereas you take S3, S3 it is being heard in the first rapid filling, right? It is heard in the first rapid filling, whereas S4 it is being heard in the second rapid filling, right? It is being heard in the second rapid filling, that is your S4. Okay, so these are the these are the various phases of the cardiac cycle where you listen to this heart sounds. And you also need to know among all these particular heart sounds which are the high pitched sounds. Your S1 and S2, these are high pitched sounds. S3 and S4 are the low pitched sounds. S3 and S4 are low pitched sounds. And because these two are high pitched sounds and these two are low pitched sounds, high pitched sounds they are heard with the diaphragm, right? Whereas low pitched sounds they are heard with the bell of the stethoscope. Okay, so this is about the brief summary of your basic heart sounds, but you need to know the abnormalities, right? So what are the conditions where you will have loud S1? What are the conditions where you will have soft S1? The conditions where you can have loud S1 is hyperkinetic states. What are hyperkinetic states? That is thyrotoxicosis, beriberi, AV fistula, anemia, pregnancy, fever. Okay, these are all hyperkinetic states where you can have loud S1. Then mitral stenosis and tricuspid stenosis and short PR interval. Short PR interval means where the PR interval will be less than 120 milliseconds. What are the conditions where you can have soft S1? The conditions where there is decreased conduction of the heart sounds to the surface of the chest. Where can you have? In obesity, emphysema, left-sided pleural effusion, pericardial effusion, right? Calcified MS and TS you will have soft S1, whereas organic MS and TS you will have loud S1. MR and TR, there is incomplete closure of your mitral and tricuspid valve in MR and TR, thereby you will have soft S1. Prolonged PR interval, that means when the PR interval is more than 200 milliseconds, where you can have soft S1. Okay, so that was abnormalities related to your first heart sound. Now let me just discuss about the second heart sound. So in second heart sound abnormalities, what will be asked for you is regarding the split. See, your S2, it has two components, A2 and as well as P2. So if you take the split, what is the physiological split? The physiological split is that during inspiration, you listen the split. But this particular split, during expiration, it disappears. During expiration, the split disappears. Okay. Now, what are the conditions where you will have wide split? So there are two conditions in this question where you can have wide split. That is in VSD and as well as ASD, you can have this particular wide split. Okay. Wide split in the sense during inspiration itself, the split will be more than the normal. That is what is called wide split. What are the other conditions? See, in order to have the wide split, there should be an early A2 or delayed P2. Early A2 you can have in two conditions, MR and as well as the VSD. And delayed P2 you can have that in ASD, atrial septal defect, pulmonary stenosis, right bundle branch block, then left ventricular ectopic beat and left ventricular paced beat. So these are all the conditions where you will have delayed P2. So overall in all these conditions, you will have wide split S2, right? Wide split S2. Now you should know the conditions where you will have wide fixed split. What do you mean by wide fixed split? That means split will be there during inspiration and the split will be there even during expiration. That is called wide fixed split. Okay. So the wide fixed split is seen in all these conditions except the options you can go through. And remember, in VSD, you will have wide variable split. That means what? During inspiration, you will have split. During expiration, the split disappears. Whereas in ASD, pulmonary stenosis and acute right heart failure, you will have the wide fixed split. Okay. Next question. This was a PYQ which was asked. Second heart sound is best heard at. Remember, second heart sound is best heard at the Erb's point. That is third left intercostal space, parasternal line. That was related to the abnormalities of second heart sound. Then you take the third heart sound. Third heart sound is best heard with, remember, it is best heard with the bell of the stethoscope because it's a low pitched sound. Next, third heart sound is best heard at aortic area, pulmonary area, the mitral area and as well as tricuspid area. Remember, it is heard at the apex. That is the mitral area. Okay, it is heard at the apex. That is mitral area. Okay, right. Now, which conditions you will have physiological S3, which conditions you will have pathological S3. Remember, physiological S3 you will have that in case of children, pregnancy, and as well as the young adults. What do you mean by the word young adults? Young adults means age less than 40 years. And you also have that in athletes. Even in athletes, you can have physiological S3. But in sumo fighters, you don't listen this physiological S3, right? Because they are morbidly obese. And your S3 is a low pitched sound. You cannot listen this, okay? Then pathological S3. Pathological S3, you will have that whenever there is development of ventricular dysfunction. That is right ventricular dysfunction, left ventricular dysfunction, cardiomyopathies like dilated cardiomyopathy, restrictive cardiomyopathy, hypertrophic cardiomyopathy. So all these conditions. So any condition which is causing ventricular dysfunction, you will have S3. That is ischemic heart disease, valvular heart disease, hypertension. So all these conditions, if you take, ultimately the individual will develop ventricular dysfunction. Thereby, you will have this pathological S3, right? Then coming to the physiological S3. Sorry, coming to the S4. Physiological S3 already we have discussed. Children and young adults, pregnancy, athletes. Done. Now coming to your S4. If you take this particular S4, this is a low pitched sound, right? And where will you listen this S4? In the second rapid filling. That means just before the systole. That is the reason why it is called pre-systolic sound, right? And this second rapid filling is due to stronger atrial contraction. That is when you get this S4. And S4 is never present or never heard in a normal individual. If you want to listen S3 and S4 in a normal individual, you require phonocardiograph. And if you are listening with a stethoscope, that means they are pathological. If S4 is heard with stethoscope, it is always pathological. And where is it heard? It is heard at the apex. And the intensity of the S4, it is accentuated by mild isotonic or isometric exercises. Now, what are the etiologies that will be causing the S4? Just remember the mnemonic HOCM. H already just now I have discussed, that is the hypertrophic obstructive cardiomyopathy. Right. So these are your heart sounds. These are the heart sounds. So your fourth heart sound, that mnemonic is what? That is HOCM. H stands for your hypertrophic obstructive cardiomyopathy, and the other obstructive heart diseases like your aortic stenosis and pulmonary stenosis. C stands for cardiac tamponade. M stands for myocardial infarction. So these are the conditions where you will listen the fourth heart sound. Then what are the additional sounds? The additional sounds are ejection click, opening snap, pericardial knock, and then the tumor plop. If you take the ejection click, you will listen that in aortic stenosis and as well as pulmonary stenosis. Opening snap, you will listen that in MS and TS. Pericardial knock, you will listen that in constrictive pericarditis. Tumor plop, you will listen that in patients with the myxoma. And out of all these, please remember your tumor plop, it is a low pitched sound. The remaining all are the high pitched sounds. Ejection click, opening snap, and pericardial knock, all these are the high pitched sounds. Okay, so this was about your heart sounds. And one more point you need to remember is your ejection click is a systolic sound. The remaining all are diastolic sounds. The remaining all are diastolic sounds. So this is about the additional sounds that you will have in the cardiology. Then next important topic is the jugular venous pressure. So what exactly the jugular venous pressure tells you about? It tells you about the right heart pressure. And in the jugular venous pressure, you need to know about the waves. These waves include A, C, X, V and Y. So now you need to know why these particular waves appear, and you need to correlate this with the cardiac cycle as well. So you take this A wave. A wave, it corresponds to the atrial contraction. A wave, it corresponds to the atrial contraction. And this A wave, it corresponds to which phase of the cardiac cycle? This corresponds to the end diastole. Right? That is nothing but the end diastole. Now C wave, it corresponds to bulging of the cusp, and that occurs during isovolumetric contraction phase, that is early systole. Then ACX, X is what? That is the atrial relaxation. So X wave, it corresponds to the mid systole, and V wave, it is due to venous filling, right? And this particular V wave, that is venous filling, it corresponds to the late systole. And Y wave is atrial emptying, and this corresponds to the early diastole. Right, this corresponds to the early diastole. Okay, So this is a quick revision of the correlating mechanical events in the JVP with the cardiac cycle. Now you need to know the abnormalities of the JVP. That is the conditions where you have abnormalities of the A wave. Absent A wave, you come across this in atrial fibrillation. Giant A wave, you come across this in right atrial myxoma, tricuspid stenosis, pulmonary stenosis, and pulmonary hypertension. Okay, that means your right ventricular inflow tract obstruction and right ventricular outflow tract obstruction. You get this giant A wave. Then you take this Canon A wave. Canon A wave, you get this in complete heart block. You get this in case of the complete heart block, you get this Canon A wave. Okay, and one more condition is in case of the junctional rhythms. Even in junctional rhythms, you get this Canon A wave. So these are the abnormalities of the A wave, right? Then you need to know the abnormalities of the X wave. So what are the conditions where you have accentuated X wave? You get this in case of constrictive pericarditis, right? You get this in case of the restrictive cardiomyopathy, right? And you get this in patients with a cardiac tamponade. These are the conditions where you have accentuated X wave. What are the conditions where you have reversal of the X wave? That you will have in patients with the tricuspid regurgitation, right? Then abnormalities of the V wave is that what are the conditions where V wave is increased? That you will come across in patients with the tricuspid regurgitation. Lastly, you need to know the abnormalities of the Y wave. So the condition where you will have early deep Y descent is your tricuspid stenosis. Deep Y descent, you come across this in constrictive pericarditis and restrictive cardiomyopathy. Absent Y wave, you have that in patients with the cardiac tamponade. I'm very sorry for here. Right. Early deep Y descent. Yeah, early deep Y descent, you have that in tricuspid regurgitation, and slow deep Y descent is that you see in case of tricuspid stenosis. So these are the abnormalities of the individual waves. Now in the JVP, you need to know about two important terminologies, that is Kussmaul's sign and Kussmaul's respiration. So Kussmaul's sign is increase in the jugular venous distension on the inspiration, that is Kussmaul's sign. Kussmaul respiration is that you come across in diabetic ketoacidosis, where there is increase in the rate and as well as depth of respiration. That is what is called the Kussmaul's respiration. Okay, then followed by the discussion of the JVP, the next important basic topic is the arterial pulse. So in arterial pulse, the common area where the questions will be asked is about the abnormal characters of the pulse. The conditions where you have pulsus paradoxus. Pulsus paradoxus is that you see that in patients with a cardiac tamponade, where there will be fall in systolic blood pressure more than 10 millimeters of mercury during inspiration is what is called pulsus paradoxus. Pulsus alternans, where you have alternating strong and weak pulse, that is in severe left ventricular failure. Pulsus parvus attitudinus, where there is a slow rising pulse with late peaking, that is aortic stenosis. Pulsus bigeminus. Pulsus bigeminus is that you come across this in case of digoxin toxicity. In case of pulsus bigeminus, you will have a strong pulse, then you have a weak pulse, then you have a compensatory pause. Again you have a strong pulse, then weak pulse, and then you have a compensatory pause. That is called pulsus bigeminus. You come across this in digoxin toxicity. Then water hammer pulse, right, which is also called collapsing pulse or the Corrigan's pulse, you see that in case of the aortic regurgitation. Dicrotic pulse, you come across this in dilated cardiomyopathy, where you have one peak in systole and the other peak in diastole. Pulsus bispherians, where you have two peaks in systole, you come across this in hypertrophic obstructive cardiomyopathy, and then you come across this AS with AR, and even in severe AR, you have this pulsus bispherians. So this was the quick recap of abnormal characters of the pulse. Then the next important topic is regarding the murmurs. Okay, so the conditions where you have continuous murmurs, systolic murmurs, diastolic murmurs, and named murmurs. Right. So which condition following murmur is seen? So what is that you are having? You are having the turbulence across your systole, that is between S1 and S2, and across your diastole. Right, across your diastole. So where do you have this continuous murmurs? You have this continuous murmurs in patients with a patent ductus arteriosus, and you also have this continuous murmur in branched pulmonary stenosis. Right, branched pulmonary artery stenosis also you have this continuous murmurs. And the other conditions where you can have this continuous murmur is ruptured sinus of Valsalva, you can have the continuous murmurs. And you can also have in AV fistulas, coronary AV fistula and as well as peripheral AV fistula, you can have this continuous murmurs. And the physiological continuous murmur, you can have that in case of mammary souffle. Mammary souffle is that like where you have increased turbulence of blood flow across the mammary vessels supplying to the mammary gland that can occur during pregnancy. So these are the conditions where you can have continuous murmurs. Then followed by that, you need to know about this is what the murmur is there between S1 and S2, which is nothing but your pansystolic murmur. So the conditions where you can get pansystolic murmur is VSD, then MR, and then TR. These are the conditions where you can have the pansystolic murmur, VSD, MR, and TR. But the point is that in MR murmur will increase on expiration, TR murmur will increase on inspiration, and MR murmur will radiate to the apex, and TR murmur there is no radiation of the murmur. Okay, so that is about the conditions where you have pansystolic murmur. Next, what is that here? You have a mid-systolic click, right? You have a mid-systolic click with late systolic murmur. Mid-systolic click with late systolic murmur. That is what is the condition seen in mitral valve prolapse syndrome. In MVPS, you have mid-systolic click with late systolic murmur. Okay, right. Next. Now, yes, the conditions all except what exactly is this? The murmur is intensified in the mid part of the systole. So, this is mid-systolic murmur or ejection systolic murmur. You have this in AS, PS, and as well as the HOCM, but not in case of TS. In tricuspid stenosis, what you get is the mid-diastolic murmur. So that was about your systolic murmurs. So you should know the conditions where you have pansystolic murmur, mid-systolic murmur, late systolic murmur. Okay, right. Then early diastolic murmur is seen in, that is aortic regurgitation. So early diastolic murmur is seen in AR and as well as even in PR. Right, AR and as well as PR. That is where you get this early diastolic murmurs. Okay. Then, what are the conditions where you can get mid-diastolic murmur? You get this mid-diastolic murmur in MS and as well as the TS. Okay, so these are the diastolic murmurs. And finally, you should know the named murmurs, right? So, Caricombs murmur, you come across this in patients with a rheumatic fever. Austin Flint murmur, you come across this in aortic regurgitation. Graham-Steele's murmur, pulmonary regurgitation. And you should know this Caricombs murmur and as well as the Austin Flint murmur, both of them, they are mid-diastolic murmur. So they are like mid to late diastolic murmur, but preferably they are mid-diastolic murmur. Whereas Graham-Steele's murmur, it is an early diastolic murmur. Retard's murmur, it is seen in complete heart block, which is also a diastolic murmur. Dock's murmur, it is seen in left anterior descending artery stenosis, that is also a diastolic murmur. And Millville murmur, it is due to air emboli. So these are the named murmurs. So this completes a quick revision of all the cardiac murmurs. Systolic murmur, diastolic murmur, continuous murmur, and as well as the named murmurs. Now, after having discussed about the murmurs, then we will move on to the individual valvular heart diseases, right? That is mitral stenosis. Okay. So, yes, I'll just take voice rest for a minute. Yes. Anyone of you can answer this question? Area of mitral orifice in adults is 6 to 8 centimeter square, 0.5 to 2 centimeter square, 4 to 6 centimeter square, 1 to 4 centimeter square. What do you think is the area of, or how much is the area of the mitral orifice? Right. So the area of the mitral orifice is, right, it is 4 to 6 centimeter square. That is the area of mitral orifice in adults. Now in patients with mitral stenosis, it will be less than 2 centimeter square. Right, in mitral stenosis, it will be less than 2 centimeter square. Now, this depending upon the valve area, right, depending upon the valve area, we classify the mitral stenosis into very severe mitral stenosis, severe mitral stenosis, and progressive mitral stenosis. Very severe mitral stenosis means mitral valve area is less than or equal to 1 centimeter. Severe mitral stenosis is less than or equal to 1.5 centimeter square. Progressive mitral stenosis is that where the mitral valve area is more than 1.5 centimeter square. Okay, so this is what is your very severe, severe, and as well as the progressive mitral stenosis. Actually, previously we used to call it as mild, moderate, severe. The terminology is taken out now. What they are using now? Progressive, severe, and as well as very severe. Okay, right? And it has been classified not only based on the valve area, even based on the gradient across the mitral valve and as well as the T half time. That is the time required for half of the blood to move from left atrium to left ventricle. Okay, right. So now, if you take the etiology, what is the most common cause of your mitral stenosis? That is rheumatic fever. And we have some connective tissue disorders like systemic lupus erythematosus and rheumatoid arthritis, right? And we have some storage disorders, that is mucopolysaccharidosis, that is Hurler syndrome, that is also responsible, or that is also the etiology that can cause mitral stenosis. Now, if you take the mitral stenosis, you need to know the auscultation. How will be the heart sound in mitral stenosis? S1 will be loud. But what is the condition of mitral stenosis where you can have soft S1? That is in calcified MS, you will have soft S1. Then what is the condition where you will have first heart sound variable S1? Variable S1, you get this in atrial fibrillation, right? Then you take S2 in mitral stenosis. If you take S2 in mitral stenosis, you will have loud P2. Why is that loud P2? That is because of pulmonary hypertension, right? That will be your S2. And between S2 and S1, you have the murmur, that is the mid diastolic murmur. Okay. And in early part of diastole, you have a high pitched sound, that is the opening snap. And in later part of the diastole, there will be stronger left atrial contraction, and that we call it as presystolic accentuation. PSA stands for presystolic accentuation. So this is the auscultation in patients with mitral stenosis. And how will be the apex in patients with mitral stenosis? It is tapping type of the apex. It is tapping type of the apex. Okay, so this will be the auscultation in patients with mitral stenosis. Now, what are the complications in mitral stenosis? Remember, in patients with mitral stenosis, there is left atrial enlargement, and this enlarged left atria will be arrhythmogenic, where there will be development of atrial fibrillation. And this enlarged left atria will be compressing the esophagus, thereby there will be difficulty in swallowing. The individual will have dysphagia. And this enlarged left atrium will be compressing the trachea, thereby there will be wheeze. And this enlarged left atrium will also cause the compression of the recurrent laryngeal nerve. And once there is compression of recurrent laryngeal nerve by enlarged left atrium, there can be the hoarseness of voice. Once there is hoarseness of voice, which we call it as the Ortner syndrome. So these are the complications of the mitral stenosis. Now you need to know how to diagnose this mitral stenosis. One is by your 2D echo, definitely. Then what does the ECG shows? ECG will show you the presence of the P mitral, right? Where if you take the P wave, it is of M shape. P wave, it is of the M shape, right? M-shaped P wave. Then you also need to know, right? Then you also need to know, in order to call it as P mitral, what is the criteria? The duration of the P wave will be more than 120 milliseconds. That is when we use the word P mitral. Then followed by that, you need to know the chest X-ray. See, chest X-ray, you will have straightening of the left heart border. Why is that? That is because of enlarged left atrium. And not only that, you will have double density sign. So this is your left atrium and this is your right atrium. So double density sign is another important X-ray picture in patients with the mitral stenosis. Then 2D echo. In 2D echo, just now we have said valve area will be reduced. Then gradient across left atrium and left ventricle will be increased. Then the pressure half time will be increased. And you have this classical hockey stick appearance in the 2D echo. Why is that? That is because of the restricted motility of the anterior mitral leaflet. That will give you the hockey stick appearance, right? Then, now how do you treat these patients with the mitral stenosis? See, these patients with mitral stenosis, why do they become symptomatic? Either because of pulmonary edema, that is because of the backflow of blood, or because of your atrial fibrillation, where the individual can develop palpitations. So these patients, they have to be advised to reduce the sodium intake, and you should give the small doses of diuretics, and then you should also give beta blockers in this patient, right? Thereby, why? Because beta blockers will increase the diastolic time. Once they increase the diastolic time of your ventricle, the emptying from left atrium can increase. So that is the reason why you can also give beta blockers. Okay, so that is what you need to give in symptomatic patient. But in very severe mitral stenosis, that means when the valve area is less than 1 centimeter square, right? In such case, if the individual is symptomatic, you need to do mitral valve intervention. What is that mitral valve intervention? One is your PBMB, that is percutaneous mitral valve balloon valvotomy. That means we will introduce a balloon, and what is this particular balloon? It is the Ino balloon, and this Ino balloon is placed across the mitral valve and the balloon is opened so that the commissures of the mitral valve will be ruptured and the balloon will get opened. But what are the contraindications for your PBMV? For suppose if there is left atrial thrombus, for suppose if there is mitral stenosis with severe mitral regurgitation, or if the patient is having calcified mitral valve, in all these conditions you cannot do PBMB. So in all these conditions what you need to do is mitral valve replacement has to be done, where you need to introduce the prosthetic valve. Okay, so that is about your mitral stenosis. The next important topic is the mitral regurgitation. Mitral regurgitation, what exactly is this? It is a scenario where the mitral valves are not closing completely during the left ventricular contraction. And what is the most common etiology? Again, it is your rheumatic fever, right? Again, it is your rheumatic fever. So it could be primary valve pathology or secondary pathology within the myocardium. What would be the valve pathology? One is your rheumatic fever. The other conditions are endocarditis, mitral annular calcification, rupture caudate tendon. And what are the myocardial pathologies? Myocardial pathologies are mainly the cardiomyopathies, that is restrictive cardiomyopathy, dilated cardiomyopathy, and as well as the hypertrophic cardiomyopathy. So these are the one which will cause the secondary MR. And even coronary artery disease, that is which particular coronary artery disease can cause MR? That is mainly the inferior wall MI and as well as the anterior wall MI that can cause the secondary MR. Now you need to know what is the criteria to call mitral valve prolapse. Even mitral valve prolapse can cause mitral regurgitation. See, from the baseline, that is from the mitral valve annulus, if the mitral valve prolapses more than 2 mm, if the mitral valve prolapses more than 2 mm into the left atrium, then we call it as mitral valve prolapse. And in these patients with mitral valve prolapse, you have the characteristic finding. What is that characteristic finding in mitral valve prolapse? Just now we have discussed, that is they will have a mid-systolic click with late systolic murmur. That is what you will identify in mitral valve prolapse. Then you should know what are the clinical features of mitral regurgitation. The clinical features of mitral regurgitation is that these patients ultimately at one point of time they will end up in left ventricular failure. Once they develop left ventricular failure, they will develop dyspnea. And in patients with mitral regurgitation, because of volume overload of left atria gets enlarged, and that enlarged left atria will be arrhythmogenic, where the individual will develop the palpitation, that is due to atrial fibrillation. And once there is left ventricular failure, ultimately the individual will develop right ventricular failure. So you will also have the features of right ventricular failure. Then what are the signs that you will come across in MR? One is once there is atrial fibrillation, you will have irregular pulse, and there will be volume overload left ventricular hypertrophy. So how will be the apical impulse? The apical impulse will be hyperdynamic type of the apical impulse. Then, and you take auscultation. See, the S1, your mitral valve is not closing completely. So your S1 will be soft, right? You will have soft S1. Then murmur is very important here. That is the pansystolic murmur. And because there is development of left ventricular failure in this patient, you will also listen S3. And what is the reason for development of the right ventricular failure? That is due to pulmonary hypertension. So once there is development of pulmonary hypertension, you can have loud P2 and you will also have the features of right ventricular failure. So these are the signs and symptoms of mitral regurgitation. Now, dynamic auscultation in mitral valve prolapse is very important area where the question can be asked. Where in mitral valve prolapse, what did we discuss? Mid-systolic click with late systolic murmur. So any maneuver which will increase the venous return, like your isometric hand grip and as well as squatting, what will happen to the click? The click will be delayed and murmur will be shortened, right? Murmur will be shortened. Now, any maneuver which will decrease the venous return, what will happen? The click will be early, right? The click will be early and the murmur will be prolonged. That is what is the dynamic auscultation in case of the mitral valve prolapse. Then how will you diagnose your mitral regurgitation? That is mainly by your 2D echo. That is mainly by your 2D echo. Then what is the treatment in these patients? You need to give diuretics, and once they develop atrial fibrillation, you need to give digoxin. Then beta blockers can be given, right? Beta blockers can be given. Now, when is that these patients they will be requiring surgical intervention? These patients, once the ejection fraction is reduced to less than 50%, with symptoms, they require mitral valve replacement. That is where they require the prosthetic valve intervention. Okay, so that was about your mitral regurgitation. The next important valvular pathology is aortic stenosis. See, how much is the normal aortic valve area? Normal aortic valve area is 3 to 4 centimeters square, right? And if the aortic valve area is reduced to less than 2 centimeters square, that we call it as the aortic stenosis. That we call it as aortic stenosis. Now, what is the most common cause of the aortic stenosis? The most common cause of the aortic stenosis in children, if you take, that will be bicuspid aortic valve, right? Whereas if you take in adults, what is the most common cause of the aortic stenosis? That will be calcified aortic valve. That will be calcified degenerative aortic valve. That is what you will see in adults. That is the most common cause. And the other causes include the rheumatic fever and all. Now, what is the triad in patients with aortic stenosis? That is SAD, syncopal attack, angina, and as well as dyspnea. Why is that they will have syncopal attack? Due to decreased cerebral perfusion, because there is aortic stenosis, because cardiac output will be reduced. Why is that they have angina? Because there will be left ventricular hypertrophy. So myocardial oxygen demand is more, but supply will be less. Okay, and thereby there will be angina. Dyspnea, because there is development of left ventricular failure. Then what will be the examination finding? They will have narrow pulse pressure. So why is that they will have narrow pulse pressure? Because systolic blood pressure will be reduced. And what is the characteristic apical impulse? The characteristic apical impulse will be the heaving type of the apical impulse. And if you take the heart sounds, like you will have S1 and as well as S2, that will be there, right? And this particular S2, you have that abnormality. What is that abnormality in S2? That A2 will be absent. Why? Because the valve which is closing, it is closing very slowly because it has been calcified. So that is the reason why the A2 will be absent, right? Then what is the treatment? Remember, if the patient is symptomatic, they have to undergo the surgical resection or surgical correction. Okay, they have to undergo surgical correction once the individual is symptomatic. So that is about the aortic stenosis. Then followed by that, the aortic regurgitation. So you take the aortic regurgitation, right? Which of the following is not the cause of aortic regurgitation? Acute MI, Marfan syndrome, rheumatic, and infective endocarditis. Remember, your acute MI can cause mitral regurgitation, but not the aortic regurgitation. So this is one of the PYQ, right? Then, so if you take the causes of the aortic regurgitation, you have primary valve diseases and primary aortic root diseases. Primary valve diseases will be rheumatic, infective endocarditis, and congenital bicuspid aortic valve. Then primary aortic root disease, that will be Marfan's, osteogenesis imperfecta, severe hypertension, ankylosing spondylitis, and as well as syphilis. And in aortic regurgitation, what is very, very important that you need to know is that in chronic aortic regurgitation, you have certain signs that you need to remember. Corrigan's pulse. What is that Corrigan's pulse? That is collapsing pulse, which is also called water hammer pulse. Then Demoset sign, that is to and fro head nodding with each cardiac cycle, is called Demoset sign. Then Muller sign. Muller sign is the pulsations that can be seen within the uvula is called Muller sign with each cardiac cycle. Then Quincke's sign. Quincke's sign is the pulsations that can be seen over the digits on compression with each cardiac cycle. That is Quincke's. Trop sign. Trop sign is nothing but the pistol shot sounds that you listen over the femoral artery on auscultation with each cardiac cycle. Then Durossi's sign. Durossi's sign is that where you have a murmur that can be heard whenever you compress the femoral artery. Then Hill sign. What is Hill sign? The Hill sign is that the systolic blood pressure within the femoral artery is more than the brachial artery by more than 20 millimeters of mercury. That is called Hill sign. And if the Hill sign is more than 60 millimeters of mercury, that tells you it is a severe aortic regurgitation. And let me tell you, all these peripheral signs are seen only in chronic aortic regurgitation, but not in case of the acute aortic regurgitation. So please remember, this is a very, very important point. Then how do you treat these patients? These patients, they should not be given beta blockers, because beta blockers will increase the diastolic time, thereby the regurgitation increases. So you need to give vasodilators like ACE inhibitors or ARBs, and as well as the aldosterone antagonists. Then when is that these patients, they require the surgery? When the ejection fraction is reduced to less than 55%, or when the left ventricular end systolic diameter is increased to more than 55 mm, that is the point when they require the surgical correction. Okay, so that is about your valvular heart diseases, that is your MS, MR, mitral valve prolapse, AS and AR. Then the next important point of discussion is the pericardial disorders. So in the pericardial disorders, you need to know about the acute pericarditis first. Okay. So like this is how the presentation in case of the acute pericarditis, right? So they will have substernal chest pain and the pain is worse with inspiration, right? And it is reduced by maintaining the upright posture. Fever recently, that is because of your viral infection, right? And ECG shows the ST segment elevation in all the precordial leads and concomitant PR segment depression. What do you think is the most likely diagnosis, right? So these patients, they have acute pericarditis, and acute pericarditis, what is the drug of choice? That will be NSAIDs. Only if the individual is refractory to NSAIDs, then we give your corticosteroids, that is prednisolone. And what is the most common cause for acute pericarditis? It is secondary to viral infection. And what is that viral infection? That is mainly the Coxsackie A and as well as B virus. And you need to know the diagnostic triad in acute pericarditis. In that diagnostic triad is the chest pain will be there. That is pleuritic type of chest pain, which increases on inspiration, and pericardial friction rub that will be there on auscultation. Then ECG changes, that is the ST segment elevation will be there in all the leads except AVR. PR segment depression will be there in all the leads except AVR. Then next is the fever, that is because of the viral infection, and this is the ECG that is suggestive of the acute pericarditis. And what is the treatment I have said you? That is the NSAIDs. Only if the individual is refractory, then we give prednisolone, that is steroid. Okay. Then next important pericardial disorder is the constrictive pericarditis, right? So what exactly is the constrictive pericarditis? It is a scenario where the pericardium is thick, calcified and scarred. Okay. So you see this question. A 45-year-old woman complaining of increasing shortness of breath on exertion. There is orthopnea for the previous 3 to 4 months. She has apparently recovered from pericarditis about a year earlier. On ECG, there is low voltage complexes, especially in the limb leads. The chest X-ray shows pericardial calcification. The presumptive diagnosis is constrictive pericarditis. Which of the following physical signs would be consistent with this particular condition, right? So definitely, what is this suggestive of constrictive pericarditis? So the options are like increased jugular distension on inspiration, third heart sound, fourth heart sound, loud first and second heart sound. Remember, in constrictive pericarditis, you have the presence of the Kussmaul sign, which is nothing but your increased jugular distension on inspiration. So the answer is A, right? The answer is A. Now let me discuss about the constrictive pericarditis. So constrictive pericarditis, you see the pericardium, it gets thickened, and how much the pericardium will be thickened? That will be more than 4 mm. That will be more than 4 mm, where pericardium is thick, calcified and scarred. And this particular thick pericardium will not allow the ventricles to relax. Okay, so this thickened pericardium will limit the diastolic filling of the ventricle, right? Will limit the diastolic filling of the ventricle. Okay, that is a very, very important point related to the constrictive pericarditis. Then what is the most common cause of constrictive pericarditis? Constrictive pericarditis is usually the sequelae of pyopericardium. Pyo means pus. This particular pus will become thick and calcified and will result in constrictive pericarditis. And the other conditions are the tuberculous pericarditis. One of the very, very important sign you will see in constrictive pericarditis is the square root sign. What is the square root sign? Square root sign, it is the cardiac catheterization finding within the ventricle during the cardiac cycle. You have it. This is within. So these are basically ventricular pressure changes. These are basically the ventricular pressure changes. Now you take this particular dip. Why do you get this particular dip? That is due to decrease in the pressure within the ventricle during diastole. Once there is a decrease in the pressure within the ventricle, the blood from atria gush into the ventricle. So thereby, right, thereby there will be elevation. And after a period of time, further filling of the ventricle does not occur. Why? Because your thickened pericardium will not allow further relaxation. So thereby the pressure will remain constant. So further filling does not occur, and that will result in plateau. Okay. So the diastole, whatever is there, it is not complete diastole. The later part of the diastole is impaired. So thereby you get this particular plateau phase. Okay. And you need to know one of the very important sign, that is called broad bend sign. What is this broad bend sign? Where you have a tapping apex. In case of constrictive pericarditis is called broad bend sign. Then in the auscultation, In constrictive pericarditis, along with S1 and S2, you get an additional sound. What is that additional sound? That additional sound will be pericardial knock. Why do you get this pericardial knock? You get this pericardial knock because the pericardium, whenever it is relaxing, or the heart, whenever it is relaxing, endocardium and myocardium will relax. But pericardium is thickened and calcified and it will not allow the relaxation. So this endocardium and myocardium, whenever it is relaxing, it will relax and it will hit the thickened pericardium, and thereby you get a pericardial knock. This pericardial knock, it is a diastolic sound. It is the high pitched sound. Right? So that is the additional sound. Now, in case of constrictive pericarditis, what will be the ECG changes? The ECG changes is that you will have low voltage complexes, where you will have the chest leads, the dimension, the amplitude will be less than 10 mm, whereas in limb leads, the amplitude will be less than 5 mm. Okay, low voltage complexes. Even in restrictive cardiomyopathy, constrictive pericarditis, pericardial effusion also, you will have low voltage complexes. Then, when you do a chest X-ray in patients with a constrictive pericarditis, what is that you will notice is that the calcified pericardium, but this calcified pericardium can be easily appreciated in the lateral view of the chest X-ray, right? Very best appreciated in the lateral view of the chest X-ray. Then, next is the your 2D echo. The 2D echo, it will demonstrate the septal bounce, right? It will demonstrate the septal bounce along with the thickened pericardium. What is that septal bounce? During inspiration, the interventricular septum will be bounced to left ventricle, and during expiration, the interventricular septum will be bounced towards the right ventricle. That is what is called septal bounce, that can be demonstrated within the 2D echo. And another important thing is the CT scan. So CT scan, that will show you that the pericardium is being thickened more than 4 mm, right? More than 4 mm. That is what you will see within the CT scan. And there are certain MRI techniques that will demonstrate the septal bounce as well. Then how do you treat these patients? You need to give diuretics and salt restriction. Then pericardiectomy should be done if the individual is refractory to the medical management. Okay, so that is about your pericardial disorders, that is acute pericarditis and as well as the constrictive pericarditis. The next important topic for the discussion will be the hypertension. Now let me discuss the hypertension in detail. Okay, right. So you see this clinical scenario. This is one of the PYQ. Right, previous year question. A 44-year-old woman presents with episodes of headache associated with anxiety, sweating and rapid pulse rate. At the time of her initial consultation, blood pressure is 150/95, but 24 hours ambulatory monitoring shows a peak of 215/130 millimeters of mercury associated with symptoms described above. Which of the following would be your initial diagnostic procedure? So all these points are in favor of what? All these points are in favor of your pheochromocytoma. Why? Because anxiety, sweating, headache, higher blood pressure, all these points are in favor of your pheochromocytoma. So in pheochromocytoma, you need to do measurement of urinary metanephrine levels over 24 hours. That will be the first line test. Then followed by that, you need to do plasma metanephrine levels. Then followed by that, you need to do plasma metanephrine. This will be the confirmatory test. Right? This will be the initial screening test. This will be the initial screening test. Okay, right. Then what are the types of hypertension? You have primary hypertension and as well as secondary hypertension. Primary hypertension is nothing but your essential hypertension. We don't know what exactly is the cause. But secondary hypertension is that where you have an underlying etiology that is responsible for the development of hypertension. Like for example, most common cause of hypertension, if the question is asked, that will be essential. We don't know what exactly is the cause. 85% will be the essential hypertension itself. Then what is the most common cause of secondary hypertension? That will be your renal parenchymal diseases like glomerulonephritis and all. And all these are your secondary causes for hypertension, but the most common cause will be the renal parenchymal cause. Then you should know what are the common causes for the isolated systolic hypertension. That includes atherosclerosis, aortic regurgitation, patent ductus arteriosus, thyrotoxicosis and coarctation of aorta. Then what are the conditions where you have unequal blood pressure between the right and as well as left arm? Unequal blood pressure between the right and left arm, you come across this in patients with Takayasu, coarctation of aorta, supravalvular aortic stenosis, aortic dissection and as well as the obstructive aortic arteritis. Now in supravalvular aortic stenosis, you need to know about a very important defect or effect that is called as the Coanda effect. What is Coanda effect? Coanda effect is that, see, this is what is your supravalvular aortic stenosis. Whenever there is supravalvular aortic stenosis, the pressure at this point will be very high, that is at the supravalvular stenotic area, and this pressure is initially transmitted to the right brachiocephalic trunk. So the pressure here will be very high, whereas in the left arm the pressure will be low. So supravalvular aortic stenosis, because of Coanda effect, you have this unequal blood pressure between the two arms. So what are the conditions? Takayasu arteritis, coarctation of aorta, then supravalvular aortic stenosis, aortic dissection, and then the obstructive aortoarteritis. These are all the conditions where you have the unequal blood pressure between the two limbs. Then what are the classification which we are following now? The one what we are following now is the JNC 8. So in elderly individuals, when will you call hypertension? It should be more than 150 by 90. In adults, it is less than 140 by 90. And in individuals who are having risk factors like coronary artery disease, diabetes, CKD, in them, the blood pressure that you need to maintain is less than 130 by 90. Elderly, less than 150. Adults, less than 140. Individuals with risk factors, less than 130. Right? So JNC 8 is what we are following now. Now, in the treatment of hypertension, what is very, very important is lifestyle modification. Like weight reduction is very important. You have to maintain the normal BMI, where your blood pressure can be reduced with, for every 10 kg reduction, 5 to 20 millimeters of mercury can be reduced. The diet, DASH diet, the diet which is rich in fruits and vegetables, that can reduce the systolic blood pressure by 8 to 14. Dietary sodium reduction. So per day, only 6 grams of sodium chloride. That can reduce the systolic blood pressure by 2 to 8. And physical activity, that is 30 minutes of brisk exercise 5 days in a week, that will reduce the systolic blood pressure by 4 to 9 millimeters of mercury. Moderate alcohol consumption, that is 2 drinks in males, 1 drink in female, then that will reduce the systolic blood pressure by 2 to 4 millimeters of mercury. And if the question is asked, what is the first line antihypertensives? In all the age groups, either calcium channel blocker or diuretics, and that too which diuretic? Thiazide diuretic. That is the first line antihypertensive. Then the next question is, when do you use the word resistant hypertension? Resistant hypertension is that when goal is not achieved, when the patient is taking 3 drugs of different classes, maximum dose, and out of the 3 drugs, 1 drug should be a diuretic. 1 drug should be a diuretic. Okay, so that is what is your resistant hypertension. Right, so here 3 drugs, so it is like 2 plus 1, and all these particular drugs should be of different classes. Maximum dose. When do you call resistant hypertension? 5 drugs, different classes, maximum dose, still the blood pressure is not reduced, then it is refractory hypertension. What is the most common cause of resistant hypertension? That is non-compliance. That is the most common cause of the resistant hypertension. Okay, so this completes the discussion of this important topic, that is hypertension. Now we'll move on to the next topic, that is the infective endocarditis. So infective endocarditis, it is one of the condition where the cardiac condition where there will be a very high grade fever. Why is that? Why? Because in these individuals with infective endocarditis, you have the vegetations, and these vegetations which are there within the endocardium, and these vegetations are infective vegetations, and these vegetations are highly friable vegetations. Because these are infective vegetations, the patient will present with the high grade fever, right? And if the question is asked, like what is the more, see, these vegetations are not just seen only in patients with infective endocarditis. You come across these vegetations in SLE, Liebman-Sachs endocarditis, rheumatic endocarditis, and as well as the infective endocarditis. But the most friable, you come across this in patients with the infective endocarditis. Okay, most friable will be infective endocarditis. Next, you should know what is the most common organism that will be causing infective endocarditis. The most common organism is the Staphylococcus aureus, right? Then accordingly, the infective endocarditis is classified depending upon the virulence of the organism. Acute infective endocarditis, it is a highly virulent organism, that is your Staphylococcus aureus, right? And it is the native valves which are being affected. That means the previously normal valves. That is what is your acute infective endocarditis. Whereas your subacute infective endocarditis, that will be the low virulent organism. So if you take this low virulent organism, these low virulent organisms will be the Streptococcus. And here the previously injured valves, right? Here previously injured valves are they affected in subacute infective endocarditis. And infective endocarditis in IV drug abusers, it is the right sided valves which are commonly affected, and the organism is mainly the Candida and as well as the Staph. Okay, that is the infective endocarditis, right? Then coming to prosthetic valve endocarditis, right? Early prosthetic valve endocarditis which will occur within 60 days, and after 60 days it is late prosthetic valve endocarditis, and you need to know the organisms, right? So you take less than 2 months, right? What? Yes, can anyone tell me what is the organism less than 2 months? That is coagulase negative staphylococcus, that is Staph epidermidis, right? So less than 2 months and as well as 2 to 12 months, the organism is the same, that is the Staph epidermidis. Okay, right? Then beyond 12 months, then you have Strep viridans, then you have Staph aureus, right? Whereas less than 2 months and 2 to 12 months, it is the same, that is Staphylococcus epidermidis, that is coagulase negative staphylococcus. Next, you need to know what is called the Austrian syndrome or the Osler's triad. So the Osler's triad, it includes three things: pneumonia, meningitis, infective endocarditis, and the organism is the strep pneumonia, right? Three major organs are affected. Next, you need to know, for the development of infective endocarditis, there should be an underlying risk factors. Okay, so which of the following cardiac lesion is at highest risk of occurrence of infective endocarditis? ASD, MVP without MR, then AR, and then the mitral stenosis. Remember, it is AR which is having the highest risk of development of infective endocarditis. So you need to know the high risk lesions, moderate risk lesions, and low risk lesions. High risk lesions are mainly the aortic lesions, that is AS and as well as MR. Sorry, AS and AR. And then even the mitral valve lesion, and that mitral valve lesion will be MR. Apart from that, congenital heart diseases like patent ductus arteriosus, tetralogy of Fallot, coarctation of aorta, ventricular septal defect, they are all high risk lesions. Whereas what are the moderate risk lesions? They are mainly stenotic lesions, that is MS, PS, TS, right? Then MVP with MR, these are all your moderate risk lesions. Which are the low risk lesions for the development of infective endocarditis? ASD and as well as MVP without MR. These are the low risk lesions for the development of infective endocarditis. And infective endocarditis image based questions are very, very important. That is, in patients with infective endocarditis, you can have the development of the splinter hemorrhages. Then within the palm and sole, you have two important structures. Okay, so in the tip of the fingers, you have the development of this Osler's nodes, right, which are very tender nodes. Then you have the Janeway lesions, and if you take these Janeway lesions, these are non-tender. These are the non-tender. Okay, right. Then followed by that, yes, in these patients with infective endocarditis, there can be development of digital infarcts. Why? Because the vegetations are highly friable vegetations. These friable vegetations, they can rupture and can enter into the digital circulation. Once they enter into the digital circulation, the blood supply to the digits can be reduced. That will result in the digital infarcts. Okay, and within the retina, what is that you will observe within the retina in infective endocarditis? That is the retinal hemorrhages, and that we call it as the Roth spots. Okay, right? So Janeway lesions are seen in the palm. Osler's nodes are seen within the pulp of the finger. And what is the name of the criteria for your infective endocarditis? That is Duke's criteria. And you have Duke staging for carcinoma rectum, Duke scoring for chronic stable angina. Then you need to know the major criteria. Major criteria, the 2D echo will be showing the large vegetations. And then the culture. What about the culture? The culture more than or equal to 2 cultures should be positive, right? More than or equal to 2 cultures should be positive, and these two are your major criteria. Then what are the minor criteria? Number 1, there should be an underlying predisposing lesion. Number 2, high grade fever should be there. Number 3 and 4 are important: vascular phenomenon, immunological phenomenon. Which are all your immunological phenomenon? This is a PYQ, right? So glomerulonephritis, Osler's nodes, Roth spots, and rheumatoid factor. Immunological phenomenon. What did they add is, which among the following is not an immunological phenomenon? They have added your Janeway lesions in one of the options. Janeway lesion is a vascular phenomenon. What are all your vascular phenomenon? Mycotic aneurysms and Janeway lesions. These are the vascular phenomena. Then microbiological evidence which is not meeting the major criteria. If one culture is positive, we take it into the minor criteria, right? So this is about your Duke's criteria. Then finally, you need to know the treatment in patients with the infective endocarditis. So even before the advent of the culture, you need to start the empirical treatment. What is the empirical treatment? that is ceftriaxone, and as well as vancomycin should be started empirically. And once the culture and sensitivity comes, you need to give the antibiotics accordingly. And one of the form of infective endocarditis where there is worst prognosis will be the fungal endocarditis. Right? Fungal endocarditis, they'll have worse prognosis. And what is the most common organism? Candida. And these patients, they will be requiring lifelong antifungal drugs, right? That is amphotericin B. And surgical treatment, it is often recommended. Which is the incorrect statement here? That is, these patients, they will have bad prognosis, right? Bad prognosis. So there are two important organisms. One is your Candida, the other one is the Aspergillus. And what are the risk factors for the development of fungal endocarditis? That is IV drug abuse. And these patients, they require medical management in the form of amphotericin B and flucytosine, then surgical treatment, that is radical surgical debridement. Okay. So, and these antifungal drugs, whatever are there, they should be given lifelong, right? They should be given lifelong. Okay. So, now the first important thing is the pericardial effusion and as well as cardiac tamponade. First of all, what is the normal quantity of the pericardial fluid? The normal quantity of the pericardial fluid, it is around 20 to 30 ml that is present within the pericardial space. Now, when do you call it as pericardial effusion? You call it as pericardial effusion when more than 50 ml of the fluid is accumulated in the pericardial space. We call it as pericardial effusion. Now, what is the difference between the pericardial effusion and as well as the cardiac tamponade? The difference between these two is that if the fluid which is accumulating within the pericardial space, if it is like gradual, so if it is gradual accumulation of the fluid in the pericardial space, then we call it as pericardial effusion. But if the fluid which is accumulating within the pericardial space, if it is like abrupt accumulation of the fluid in the pericardial space, that will be the cardiac tamponade. Now, please remember, it is rapidity with which the fluid is accumulating, right? It is the rapidity with which the fluid is accumulating will decide whether it is pericardial effusion or cardiac tamponade. It is not the quantity which will decide the pericardial effusion or the cardiac tamponade. See, even there can be accumulation of 200 ml of fluid also. If it is abrupt, it is called as cardiac tamponade. Even there can be 2000 ml of fluid which can be accumulated, but if it is gradual, we call it as pericardial effusion only, right? Now, if you take this pericardial effusion, so what will be the presentation in these individuals? The presentation will be in the form of the dyspnea. Why? Because they will have the diastolic dysfunction because of the accumulation of the fluid in the pericardial space. Then how do you diagnose this pericardial effusion is? Number one is it can be diagnosed by the 2D echo. That is one methodology of diagnosis of your pericardial effusion. And the other method of diagnosis is by your chest X-ray. And then the ECG. Now, what will the chest X-ray show you? So, chest X-ray will show you that there is a cardiomegaly, and if you take the pedicle of the heart, right, so you will have a narrow pedicle, right? You will have the narrow pedicle. So that is what you will observe, or that is what you will notice in case of the pericardial effusion. And this classical appearance of the heart, this is what is called as the water bag appearance or money bag appearance. And next thing is the ECG. What will the ECG show in case of pericardial effusion is, that is the presence of low voltage complexes. Now, what do you understand by this word low voltage complexes? That is, if the amplitude of the QRS complexes, if it is less than 10 mm in the chest leads, and if the amplitude, if it is less than 5 mm in the limb leads, this we call it as the this we call it as low voltage complexes. Now, what are all the conditions where you can have low voltage complexes? One is pericardial effusion. Then you can also see this in patients with a constrictive pericarditis and even in restrictive cardiomyopathy. These are all the differential diagnoses. And other conditions like morbid obesity, COPD patients like emphysema, and massive left-sided pleural effusion. In all these conditions, you can have low voltage complexes. Then how do you treat these patients is, you need to do pericardiocentesis in order to look for what is the cause of the pericardial effusion. So you need to treat the cause of the pericardial effusion, right? So that is what is the treatment for your pericardial effusion. But whenever you do pericardiocentesis, if there is, massive pericardial effusion or cardiac tamponade, that is the point when we do therapeutic pericardiocentesis. I'll discuss that in the cardiac tamponade itself. Okay, right now. And one more important ECG finding is, for suppose if there is massive pericardial effusion, then you get what is called as the electrical alternance. Okay, you get what is called as the electrical alternance. What do you understand by this word, the electrical alternance? See, electrical alternance is that if you see this ECG, in this you don't have the electrical alternance. This is actually low voltage complex. Okay, what is that electrical alternance? Is that one complex will be tall and the other complex will be small. One complex will be tall and the other complex will be small. And this electrical alternance is not just seen only in massive pericardial effusion. You also come across this in cardiac tamponade. Cardiac tamponade, definitely the ECG finding is the electrical alternance itself. Why is that? Because the heart will be swinging in the fluid. When the heart swings anteriorly, you get large complex, and when the heart swings posteriorly, you get the small complex. That is what is your electrical alternance. See, this electrical alternance, you should not get confused with the pulsus alternance. Pulsus alternance is that where you have a larger amplitude pulse, then followed by lower amplitude, larger amplitude pulse, and then lower amplitude. Where do you get this pulsus alternance? You will get that in case of severe left ventricular failure. Okay, right. Then followed by that, the next important topic for the discussion is the cardiac tamponade. So I have said you already. So the important difference is the accumulation of the fluid rapidity. So if there is abrupt accumulation of the fluid in the pericardial space, that we call it as the cardiac tamponade. Now for this you need to understand how much is the normal intrapericardial pressure and how much will be the intrapericardial pressure that will be elevated in cardiac tamponade. See, the normal intracardiac pressure that will be around -5 to +5 millimeters of mercury. But in cardiac tamponade, the intrapericardial pressure that will be more than or equal to 15 millimeters of mercury. Now, when the intrapericardial pressure is greater than 15 millimeters of mercury, what will happen? That will restrict the venous return. That will restrict the ventricular filling. Because your intrapericardial pressure is very high, the ventricle cannot relax. Right? There will be diastolic collapse of the ventricles. There will be diastolic collapse of the ventricles. Okay. Then what will be the etiology that will be causing your cardiac tamponade? This cardiac tamponade, it can occur secondary to the chest trauma. It can also occur secondary to the rupture of the aortic aneurysm, right? Secondary to the penetrating trauma to the chest. These can cause the cardiac tamponade. And not only that, cardiac tamponade can also be seen in chronic renal failure. That is, due to the fluid overload, there can be even cardiac tamponade. Now, what will be the clinical features in these patients with the cardiac tamponade? The clinical features is they will develop sudden onset dyspnea, right? They will develop sudden onset dyspnea. Now, what is the cause for sudden onset dyspnea? Because there is diastolic collapse of the ventricle. So there is complete backflow of the fluid from the left ventricle to the left atrium, from the left atrium into the pulmonary veins, then into the pulmonary capillaries, causing pulmonary edema, and that is a cause for sudden onset dyspnea. Now you take this characteristic triad that is called as the Beck's triad. Now what is this Beck's triad in case of the cardiac tamponade is that number one, there will be raised JVP. Number two, you will have muffled, okay, so there will be hypotension and there will be muffled heart sounds. So this is what is the Beck's triad in case of the cardiac tamponade. Then how will be the JVP? The JVP will be elevated, but one important point you have to remember is that the Kussmaul sign will be absent in patients with the cardiac tamponade. And what will be the characteristic pulse in cardiac tamponade? The characteristic pulse will be pulsus paradoxus. Right? What exactly is your pulsus paradoxus? Where there will be fall in your systolic blood pressure more than 10 millimeters of mercury during inspiration is what is called pulsus paradoxus. And how will be the heart sounds? The heart sounds that will be muffled heart sounds. And what will the 2D echo will be showing in cardiac tamponade is, in cardiac tamponade, you will notice that there is diastolic collapse of the ventricle. Right? There is diastolic collapse of the ventricle. And ECG, just now we were discussing that there will be electrical alternance, right? Where you have alternating large and small complexes. And what is the immediate treatment that you need to do in cardiac tamponade is you need to do pericardiocentesis. Now, whenever you are doing this pericardiocentesis, what should be the approach? The approach should be subxiphoid approach. So through subxiphoid approach, you need to do the pericardiocentesis where you need to take out the pericardial fluid. Now, this is what is the ECG of the electrical alternance, where you have large and as well as the small complexes. Large and as well as small complexes. This is the ECG of the cardiac tamponade, right? So with this, we are done with the pericardial effusion and as well as the cardiac tamponade. And next important topic in the cardiology which is left out is the coronary artery disease. In the coronary artery disease, what is the most common cause of the coronary artery disease? That will be atherosclerosis. Right? You have many other risk factors, right? But one of the very important cause for coronary artery disease will be atherosclerosis. And other risk factors like smoking, family history, diabetes, hypertension, sedentary lifestyle, excessive stress, these all can contribute to the development of the coronary artery disease. Now, if you see the spectrum of the coronary artery disease, we classify that into ischemia and as well as infarction. So, ischemia is what? Ischemia is that where there is only decreased blood supply to the myocardium, whereas infarction is that where there is death of the myocardium. And in both of them, please remember the manifestation will be the same, that is chest pain. But what is the characteristic difference is the cardiac biomarkers. Right, the characteristic difference is the cardiac biomarkers. The cardiac biomarkers in case of the ischemia, it will be negative, but whereas cardiac biomarkers in case of infarction, they will be positive. What are those cardiac biomarkers? That is your troponin, your CKMB, all that I'll tell you now. So now what will be the the spectrum in the ischemia, that is stable angina, principal angina and unstable angina. Whereas in case of infarction, depending upon the ECG changes, we classify that into non-ST elevation MI and as well as ST elevation MI. Now let me discuss about the individual parts of the spectrum. So the first thing is the stable angina. So stable angina, the another terminology which is being given to this is, it is also called reversible ischemia. And what will be the duration of the chest pain in case of chronic stable angina is, the duration will be around 10 to 15 minutes. And this particular chest pain will be retrosternal, and this chest pain, it increases on exertion. And this chest pain, it reduces on taking rest or on taking sublingual nitrate. So on taking sublingual nitrate or taking rest, if the chest pain reduces, which is of duration of less than 10 to 15 minutes, that will be chronic stable angina. Now, these patients, whenever they are describing the chest pain, they will clutch the fist over they'll clutch the hand in the form of a fist. They'll clutch the hand in the form of a fist over the precordium while describing the chest pain, and that is what is called as Levine sign. And but in these patients with those patients with diabetic autonomic neuropathy, they don't have this angina. They can have silent MI. So what will be the angina equivalent will be the dyspnea. And the ECG in case of chronic stable angina, you don't have any specific changes. You have non-specific STT changes. Then what will be the diagnostic investigation for your chronic stable angina? That is treadmill test or dobutamine stress echo should be done. So when you do a treadmill test, like while doing the treadmill, if you have the development of ST segment depression more than 0.1 millivolts, then it is suggestive of the TMT to be positive, suggestive of an underlying coronary artery disease. Then what is this dobutamine stress echo? Dobutamine stress echo is that you started the injection of the dobutamine that will increase the heart rate. If there is development of new regional wall motion abnormality, then we consider it as the DSE to be positive, which is suggestive that there is an underlying coronary artery disease. And you need to know some important contraindications for treadmill test. Number one, uncontrolled cardiac arrhythmias like VTVF ongoing. Don't do treadmill test, right? And if the patient is having symptomatic aortic stenosis, that is in the form of syncopal attack or angina or dyspnea, don't do this treadmill test, okay? And what is the drug of choice in case of chronic stable angina is beta blockers. Why is that? Because beta blockers, they will reduce the heart rate and thereby they will reduce the myocardial oxygen demand, and in coronary artery disease the supply is less. So if you reduce the myocardial oxygen demand, that can reduce the progression of the chronic stable angina. They are considered as a drug of choice. And what are the other drugs that we give is, for pain we give nitrates, then the other drugs are the antiplatelets or the statins can be given. And in case of chronic angina, the drug which has been used is ranolazine. Right, the drug that has been used is ranolazine. Okay, so this is about your chronic stable angina, which is also called reversible angina or reversible ischemia. Now you need to know, or you need to be very much aware of, what is the role of imaging in coronary artery disease. See, if you see the role of imaging in coronary artery disease, we have some imaging methodologies, that is thallium 201 or technetium 99. This thallium 201 or technetium 99 is useful for detecting the hibernating myocardium. What is hibernating myocardium and what is stunned myocardium? I will discuss that. And we have a PET scan, that is rubidium, where we use the radionuclide substance, that is rubidium 82. And the purpose of this PET scan where we are using rubidium 82 is for assessment of myocardial metabolism and also for diagnosing the stunned myocardium. And electron beam CT scan, it is mainly for assessment of coronary artery calcification. And gadolinium enhanced MRI, it is a sensitive test to detect and quantify the extent of infarction, not infection, infarction. Okay, so that is the purpose of the gadolinium enhanced MRI. So now we are done with the chronic stable angina, and the next important part in the spectrum is what? That is Prince metal angina. Prince metal angina, it is also called as the vasospastic angina, and here the spasm will be there, right? The spasm will be there, that will be there for more than 70. The coronary artery, they undergo vasospasm by more than 75%. Right, that is the reason why it is called vasospastic angina. And these patients, they will have chest pain during that vasospasm episode, right? Only during that vasospasm episode they'll have this chest pain. And the most common vessel which is affected among the three, that is right coronary artery, left circumflex and left anterior descending artery, it is the right coronary artery which will undergo the vasospasm commonly in case of the Prince metal angina, right? And what will be the ECG changes? It is only during the chest pain you have that ST segment elevation, right? Once the chest pain reduces, that means your vasospasm is relieved, so the ST segment elevation will return back to normal. And what is the drug of choice to relieve that spasm? You need to give nitrates, and the alternative drugs are the calcium channel blocker and this new molecule, that is fasudil, right? So this is about your Prince metal angina, which is also called as the vasospastic angina. So the three important okay, so done with stable angina, Prince metal angina. Now you take these last three components, that is unstable angina, NSTEMI and STEMI. These three components, they come under what is called as the acute coronary syndrome. Now let me take up the discussion one by one. So you take the unstable angina. See, in unstable angina, the individual will have angina at rest. It is not like chronic stable angina. In chronic stable angina, the pain will be there only on exertion. But here, the chest pain, which is of retrosternal in origin, that will be there at rest, and it will be accelerating pain, right? It will be accelerating pain. The pain increases as the time progresses. And the next important is these patients, like we describe, the patient will describe as the angina which is appearing for the first time. So it is the new onset angina. Right now, what exactly is your Wellen syndrome? Let me tell you, the Wellen syndrome, it is actually an ECG manifestation, right? It is an ECG manifestation saying that there is a critical, right? Saying that there is a critical proximal left anterior descending artery stenosis in patients with unstable angina. Then what will be that ECG changes in case of Wellen syndrome? That is the T wave inversion, right? And that particular T wave inversion will be a deep T wave inversion of more than 2 mm in the precordial leads. That is from V1 to V3, you have deep T wave inversion. That is your type 1 valence. Whereas type 2 valence is what? Where you have biphasic T wave inversion. Now, the presence of the valence, what does it indicate? It represents the pre-infarction stage coronary artery disease. That means if you don't treat this pre-infarction stage, this individual from a state of pre-infarction stage, there is a very high chance that the patient may progress to the development of infarction. Right? The patient may progress to the development of the infarction. Okay, so that is what is your Wellen syndrome, right? Next, then, so that was about your the unstable angina. Then NSTEMI, so non-ST elevation MI. So three important points are there. Out of this, if two are there, we can consider it as NSTEMI. First and foremost, definitely angina is one important thing which can be there at rest. Then there will be rise and fall of the cardiac biomarkers, right? And ECG will be showing the ST segment depression. So these are the three important points. Out of three, if at least two are there, we can consider it as non-ST elevation MI. And what is the point of difference between NSTEMI and STEMI? In STEMI, see, in NSTEMI, like we consider it as subendocardial infarction, right? Subendocardial infarction. But whereas if you take in STEMI, it is transmural myocardial infarction. Right, it is the transmural myocardial infarction. Okay, right. And the treatment wise, it is different. For unstable angina and as well as NSTEMI, the treatment is same. But for STEMI, the treatment is different compared to that of NSTEMI. What is that? We will discuss. And this particular STEMI, we have totally 5 types. Type 1, 2, 3, 4, 5. Type 1, it is the spontaneous MI which is related to ischemia due to primary coronary event. What is that primary coronary event? That is the plaque rupture. So once the plaque rupture, the entire coronary artery gets 100% occluded, where the individual develops MI. that is type 1 MI. So either due to plaque rupture or due to coronary artery dissection, right, or due to coronary artery dissection, that is your type 1 MI. Then what is your type 2 MI? So type 2 MI, it is a myocardial infarction secondary to ischemia due to increased demand, right, due to increased demand and decreased supply, right, and decreased supply. So when can you have this increased demand and decreased supply is that, like in case of anemia, there is like hypoxia, there is decreased supply but demand is more because of tachycardia, like arrhythmias, hypertension. So in all these conditions like anemia, arrhythmias and as well as hypertension, so there will be increased demand and as well as decreased supply. And your type 3 MI, this is considered as the individual having a sudden unexpected cardiac death, right, including cardiac arrest. Okay, so what is the criteria to call it as sudden unexpected cardiac death? So here the death occurs before the blood samples could be obtained or the time before the rise of the cardiac biomarkers, right? Before the cardiac biomarkers have increased within the blood, the individual had death because of MI. That comes under your type 3 MI. Now your type 4 MI, that is related to your PCI. Again we have 4A and as well as 4B. So 4A is what, that this stent which has been placed, it has been blocked, and that is documented by coronary angiography. That is your if it is documented by, right, if it is documented by raising your troponin levels more than 5 times, that will be your 4A. But if it is being documented by coronary angiogram, that stent is blocked or the stent is blocked, that is identified on autopsy, that will be your 4B. Then what is type 5? It is MI which is related to coronary artery bypass graft, where the grafts have been blocked. Again the individual have developed MI, and how can you identify this? The troponin levels will be elevated, and these troponin levels which are elevated will be almost 10 times. So these are the various types of MI. And what are the features of your MI? The chest pain will be there for more than 20 to 30 minutes. And ECG will be showing you the ST segment elevation, like more than 1 mm in the limb leads and more than 2 mm in the chest leads, right? And in the reciprocal leads, you will have the ST segment depression. And ECG will be showing you regional wall motion abnormality. Coronary angiogram will show you the presence of thrombus, and cardiac biomarkers are being elevated. Now, regarding the ECG, you need to remember one important point. So, if the question is asked, what is the earliest ECG change in MI? The earliest ECG change in MI, it is not ST segment elevation, that is broad tall T wave, right? Broad tall T wave, that will be the earliest ECG manifestation in MI. Then after this broad tall T wave, the next important manifestation will be in the form of the ST segment elevation. Then what are the other changes? The other changes will be, there will be disappearance of the R wave, then there will be T wave inversion, then there will be appearance of the pathological Q wave, right? There will be appearance of the pathological Q wave, right? And once the MI has been resolved, all the changes will disappear. Only this pathological Q wave will be present. And only when the pathological Q wave is being present, that tells that the individual is having the old MI. So these are the ECG changes in MI, right? And next important thing is you need to know about the cardiac biomarkers. So what is the first cardiac biomarker that is being raised is the IMA. That is ischemia modified albumin. And this ischemia modified albumin will rise within minutes, right? And it will reach the peak value within 6 hours. And by 12 hours, it will return back to normal, right? By 12 hours, it will return back to normal. So this is the first cardiac biomarker which is being elevated. That is ischemia modified albumin. And what are the other new biomarkers? That is heart fatty acid binding globulin, right? Heart fatty acid binding globulin. And the other biomarkers which are elevated within half an hour to 1 hour will be even myoglobin. But that myoglobin is non-specific. And what is the marker of the reinfarction? You need to do the serial levels of the troponin, and within the serial levels of troponin, if there is increase in troponin value 20% compared to the previous value, that is a marker of reinfarction. But if the question is specifically asked like marker of reinfarction after 72 hours, then you can answer it as the CKMB, because CKMB will be elevated in the body only up to 3 days, and after 3 days if the patient is having chest pain once again, that is on 4th day morning, you do a CKMB levels. If the CKMB levels are elevated again, I mean, if the CKMB levels are elevated still, even after 72 hours, that tells it is a re-MI. Then LDH pattern, it is also a flipped pattern, right? LDH1 will be more than compared to that of the LDH2. So that will be flipped pattern. That is what you will observe in case of the myocardial infarction. Now let me discuss in detail about some of these cardiac biomarkers, mainly troponins and as well as the CKMB. Troponins or CKMB, both of them, they appear within the blood within 2 to 4 hours. But troponins, they reach the peak value within 1 to 2 days and they return back to normal within 10 to 14 days. That is up to 2 weeks. But you need to know the differential diagnosis. What are the other conditions where the troponins are elevated apart from your MI? That is congestive heart failure, atrial fibrillation, acute pulmonary embolism, myocarditis, chronic renal failure and sepsis. All these conditions, the troponin levels may be elevated. Then you take this CKMB. CKMB, it will reach the peak value within 1 day and it will remain elevated for up to 3 days, right? And after 3 days, it will return back to normal. And what is the differential diagnosis apart from MI? The CKMB can also be elevated in myocarditis, pericarditis, and as well as the cardiac defibrillation. So these are some of the points related to cardiac biomarkers. Now, you need to know what is a treatment. See, if the question is asked, like, what is the first line management? The first line management is that you need to give the aspirin, right? You need to give the aspirin. But for pain control, right? For pain control, you need to check the blood pressure and then you need to give the drug. So for pain control, you can give either morphine or you can give the nitrates, right? You can give the nitrates. But if the question is asked like what is the first line antiplatelet that you can give is the aspirin. And the loading doses of these particular drugs are 325 milligrams is the aspirin and 300 milligrams will be your clopidogrel and that is your clopidogrel and 80 milligrams will be the atorvastatin. Okay, or you can give 180 milligrams instead of the clopidogrel. The other drug which is being used recently is ticagrelor. 180 milligrams of ticagrelor can be given. These are the loading doses. And instead of 80 milligrams, you can give 40 milligrams of rosuvastatin as well, right? And what is the best method of revascularization in case of the ST elevation MI? That will be your PCA, that is percutaneous coronary intervention is the best method of revascularization. It can cause 100% revascularization. And what are actually various methods of revascularization? That is PCA, thrombolysis and CABG, right? The best method and immediately that can be done is the PCA. And you need to know the point here, that is door to balloon time. So door to balloon time, that will be 90 minutes. Whereas what is the door to needle time? Door to needle time will be for thrombolysis. And that door to needle time, that should be within 30 minutes. And remember, thrombolysis we do only in ST elevation MI. We don't do thrombolysis in case of non-ST elevation MI and as well as the unstable angina. Now, among these thrombolytic agents, like we have streptokinase, retiplase, alteplase and tenecteplase, right? These are the thrombolytic agents. But among all these, the maximum revascularization can be done with your tenecteplase. Remember, T for thrombolysis, T for tenecteplase. That is the one which can cause maximum revascularization among these four thrombolytic agents. Then the next is your CABG, coronary artery bypass graft. Coronary artery bypass graft preferably is being done when the patient has the triple vessel disease on coronary angiogram, or when there is severe, right, when there is severe proximal left main coronary artery stenosis is there. That is also the indication for the coronary artery bypass graft. Then what are the complications in myocardial infarction? The electrical complication, either there can be tachyarrhythmias or there can be development of the bradyarrhythmias. Tachyarrhythmias, that includes VT or VF, which are very common within 24 to 48 hours of development of MI. And bradyarrhythmias are very common in patients with inferior wall MI or right ventricular MI or posterior wall MI. Okay, now these bradyarrhythmias, that includes your Mobitz type 2 AV block, which is the most common form of bradyarrhythmia, and this can progress to even development of the complete heart block, where they require temporary pacemaker insertion once they develop complete heart block. Okay, then what are the mechanical complications that you will come across in the myocardial it is not infarction, it is not infection, it is infarction. Right. So the mechanical complications, that includes the development of the ventricular septal defect, the development of the mitral regurgitation. And this mitral regurgitation are mainly because of the papillary muscle rupture or the caudate tendon rupture. And this mitral regurgitation, it is very commonly seen in case of the anterior wall MI and as well as the inferior wall MI. So these are the mechanical complications or structural complications that you will see in patients with myocardial infarction. Then what are the late complications? Late complications include the Dressler syndrome. Now what is this Dressler syndrome? That is post-myocardial infarction pericarditis, which will develop after few days to weeks after development of MI. If it will develop after few weeks to months after development of MI. That is what is your Dressler syndrome, which is post-myocardial infarction pericarditis. So it's a pericarditis. So the individual will present with chest pain, and even the ESR is also elevated in Dressler syndrome. And what is the treatment that we give? Either we give colchicine, or we give high dose aspirin, or we give corticosteroids. So that is what is the treatment in case of Dressler syndrome. And you need to know the two important myocardiums, that is stunned myocardium and as well as the hibernating myocardium. So this stunned myocardium and as well as hibernating myocardium, as already I have said you, we can differentiate it by the imaging. Like you take hibernating myocardium, you can detect it by thallium-201 or technetium-99 scan. Whereas you take stunned myocardium can be detected by your PET scan, where the radionuclide substance that we use is rubidium-82. Right, rubidium-82. Okay, now let me discuss what exactly is your stunned myocardium or the hibernating myocardium. See, both of them, they will develop after MI, right? Both of them, they will develop after MI. But stunned myocardium refers to the state of the post-ischemic reversible myocardial contractile dysfunction that persists despite myocardial infarction. That means stunned myocardium despite myocardial reperfusion, right? Despite myocardial reperfusion, there is still contractile dysfunction. That is stunned myocardium. What is hibernating myocardium? Hibernating myocardium is that the myocardial contractility will return back to normal after reperfusion. Okay, so the myocardial contractility, right, that will return back to normal after the myocardial reperfusion. So that will be your hibernating myocardium. That will be your hibernating myocardium. So you can differentiate these two by your imaging studies, right? Then after, so this is about your coronary artery disease, quick revision. And the last important topic that is being left out is the acute rheumatic fever. So this rheumatic fever, please remember one of the very, very important point, it is not an infectious condition. It is an inflammatory condition. Why is that I am telling like it's an inflammatory condition or inflammatory disease? That is because the pathogenesis that you will see in rheumatic fever is that our immune system will act against the components of, it will act against M protein component of group A beta hemolytic streptococcal cell wall. The antibodies which are being formed against the M protein of group A beta hemolytic streptococcal cell wall, that will be acting on the connective tissue of the individual. Right, so that is why it's an inflammatory disorder and it is a recurrent disorder. Because it is recurrent, these patients, they will be requiring the penicillin prophylaxis. They will be requiring penicillin prophylaxis. Okay, and remember, it is not a communicable disease, right? And it is a immunological hypersensitivity, right? It is immunological hypersensitivity. And what type of hypersensitivity reaction is this? This will be a type 2 hypersensitivity reaction. All right, so this rheumatic fever, the type of hypersensitivity reaction is type 2 hypersensitivity reaction. Now in case of rheumatic fever, you see this question, very important, that is, most of the manifestations of acute rheumatic fever presents approximately 3 weeks after the precipitating group A streptococcal infection. Which manifestation may present several months after the precipitating infection? Chorea, erythema marginatum, fever, polyarthritis, subcutaneous nodules. So what do you think is the late manifestation? Right, very good, Himanshu. That is the chorea. The chorea is the late manifestation. Now, what is the name of the criteria? The name of the criteria is the Jones criteria, right? So in 2015, the Jones criteria have been modified into like major and minor is there, but they have divided that into the low risk population and as well as the high risk population. In case of low risk population, the chance of development of rheumatic fever is less. And as the word tells you, in high risk population, the chance of rheumatic fever is more. And all, in case of major manifestation, what all will be there? That is arthritis, carditis, right? Erythema marginatum, then chorea, okay, chorea, then subcutaneous nodules. All these will be there in low risk and high risk, but the point of difference is the joint involvement. The point of difference is the joint involvement. In case of low risk, you should have polyarthritis only, whereas in moderate and high risk population, right, in these individuals, either monoarthritis is sufficient to call it as major criteria, or polyarthritis or polyarthralgia is also sufficient to call it as the high risk criteria. Then you take minor criteria. Even in minor criteria, again we have low risk population, high risk population. So low risk population, again the joint involvement. Polyarthralgia is required for low risk, and moderate to high risk you require the monoarthralgia. Then the next is the ESR, right? The next is the ESR. So ESR, it should be more than 60 mm, right? More than 60 mm in 1 hour in case of low risk, more than 30 mm in 1 hour in the moderate and the high risk population. Okay, right. So this is how you will differentiate the low risk and as well as high risk population. And the other minor criteria are fever more than 38.5 degrees centigrade and the PR interval is being prolonged. And what is the most common earliest manifestation? Most common earliest manifestation will be the arthritis. See, arthritis will develop within 2 weeks, and the arthritis here is the non-erosive arthritis, right? Rarely you get a deformity that is called Jacob's arthropathy, right? That is called Jacob's arthropathy. See, this is what is your Jacob's arthropathy, but very rarely you get this Jacob's arthropathy, which is nothing but where you have the ulnar deviation. And the joints which are being affected here is mainly the lower limb joints. And the description of the arthritis is migratory polyarthritis. That means the inflammation will be there within one joint for 1 week, and after that the inflammation will completely subside in that joint. Next it will shift to the other joint. So that is what is called as the migratory polyarthritis. Okay, so and in these patients with arthritis, what is the drug of choice? The drug of choice for arthritis will be the aspirin. That too, we give high dose aspirin. And in those individuals who are like having development of adverse effects with aspirin, see, what is the development of adverse effect with aspirin? Development of Ray's syndrome. So those individuals who are developing Ray's syndrome, in them you can give an alternative NSAID, that is naproxen, can be given, right? And what exactly is Ray's syndrome? Ray's syndrome is that where there is development of worsening brain and as well as liver toxicity. What will be that brain pathology? The brain pathology will be in the form of the seizures, loss of consciousness, and liver pathology will be in the form of liver toxicity, where they can have the jaundice. Okay, and this Ray's syndrome, it usually begins shortly after the recovery from the viral infections such as the influenza or chickenpox. And about 90% of cases in children, they are associated with the aspirin use. The development of Ray's syndrome in children is mainly secondary to the aspirin use. So those individuals who have developed Ray's syndrome, you need to give the alternative agent, that is naproxen, can be given, right? So this is about your major and as well as minor criteria according to your Jones, right? Next, and you need to know the valvular involvement. So what is the earliest valvular lesion in case of acute rheumatic fever? So this is one of the PYQ. The earliest valvular lesion, please remember, that will be the mitral regurgitation. But if the question is asked, what is the most common valvular lesion, right? What is the most common valvular lesion in case of the chronic rheumatic heart disease? Yeah, Himanshu, I'll tell you the treatment. Just wait for a minute, I'll tell you the treatment. See, in case of chronic rheumatic heart disease, that will be the mitral stenosis. Chronic rheumatic heart disease, it is mitral stenosis, whereas the acute rheumatic fever, it is the mitral regurgitation. That will be the valvular pathology. And the valve which is least commonly affected will be the pulmonary valve. Then how do you treat these patients? So, right, for chorea, you take this rheumatic chorea. If the patient is having mild form of involuntary movements, we don't give any drug. Just provide calm environment, that will suffice. But in moderate cases of the chorea, these patients, they will be requiring the carbamazepine or valproic acid. So carbamazepine or valproic acid is preferred over haloperidol. But whereas in severe form of the chorea or refractory forms of chorea, those patients, they require the steroids. That is how you will treat this particular chorea, right? Then followed by that, in some cases, in extremely severe forms of chorea not responding to any of these drugs, small studies have suggested the role of intravenous immunoglobulin. This intravenous immunoglobulin can have rapid resolution of the chorea manifestation. Okay, so that is about the treatment in case of the chorea. Now, coming to the antibiotic prophylaxis. See, the antibiotic prophylaxis that we give is the benzathine penicillin. And this benzathine penicillin, you need to give 1.2 million units. And in which group of individuals you give this 1.2 million units? Deep IM. If the weight of the individual is more than 27 kgs, you need to give 1.2 million units intramuscularly every 3 to 4 weeks. But if the weight of the individual is, or if the weight of the child is less than 27 kg, you need to give exactly half of it, that is 0.6 million, that is 6 lakh units, that is you need to give. And those patients who are allergic to penicillin, in them you need to give sulfadiazine or erythromycin is being given. And next important is for how long you need to give the prophylaxis, right? For how long you need to give this prophylaxis. See, it all depends upon the individual manifestation. If the patient is having rheumatic fever without carditis, then you give it for 5 years after the last episode, or 21 years of age, whichever is longer. That is rheumatic fever without carditis. But if the patient is having carditis but residual valvular involvement is not there, residual valvular involvement is not there, then in such case you give 10 years after the last attack or 21 years of age, whichever is longer. But if the patient is having persistent valvular disease, right, persistent valvular disease, in such case you need to give this benzathine penicillin for 10 years after the last attack or 40 years of age, whichever is longer, and sometimes lifelong prophylaxis is being given. So this is about the story related to rheumatic fever. So with this, we are done with the topics related to cardiology. So in the cardiology, we are done with each and every topic.